Good evening and welcome. I am Lauren Gates, your host of this evening's special Airway Health Solutions event. It's our summer MYO celebration featuring our AHS faculty, Carice Laguerre, Brittany Sierra Murphy, and Dr. Ben Moralia. I am super excited because we have over 400 registered this evening. So that's a testament to advancing airway health and the importance of orofacial myofunctional therapy. So kudos to everyone joining us tonight. And it is my honor to introduce our speakers. We're just going to do an informal introduction just to welcome everyone. And those who aren't familiar with our faculty, just get a chance to know them a little bit better. So I'm going to start with you, Carice. Why don't you come off and mute and tell us a little bit about yourself and your experience as a myofunctional therapist, a hygienist, and your passion for airway.
Awesome. Well, that sounds like a lot. I wanted it to be really brief, but I'm Carice. I'm a registered dental hygienist and myofunctional therapist. I have my own practice. It's the MYO Spot, where we service clients globally through teletherapy. I am a happy resident of Florida, but I am a native of New Jersey. Very important distinction, never confuse the two. And I'm an author, a speaker, and I'm just happy to be here. I'm super excited to always talk about airway.
Thank you. Brittany?
I'm Brittany. I live in Connecticut. I have a private practice in Connecticut, CT oral facial myology, and then I also co-founded MyoAir with locations in Florida and New York. I'm a registered dental hygienist, myofunctional therapist, airway enthusiast. I have a podcast, I Spy with my MYO Eye. If you haven't checked it out, hopefully you can. And we're always looking for guests to come on. So if you want to have a convo with me about all things airway, just holler at me. Super excited to be here with you all and share a little screener that we have for our fellow hygienists.
We're excited too. Dr. Ben, why don't you come up? You're off mute. Come on, introduce yourself. So many people know you, but we do have a few new attendees tonight.
Sure. Good evening, everybody. Ben Moralia. I'm a dentist in Mount Kisco, New York, and I have been doing growth development, early intervention, orthopedics, and orthodontics for the last 20 years. And over that 20 years, it's been a really big kind of evolution into the things that we offer children and adults. But the whole biggest point about that is the inclusion of orofacial myofunctional therapy, frenum assessment and revision as needed. And those are probably two of the biggest things that have made probably the most impactful difference in the kids as far as my pathway has been. The 20 years ago when I started doing early treatment, age 3 and above, I did not include the myofunctional therapy. To be honest, 20 years ago, I didn't really know it existed. And so shame on me. But as a general dentist, I was doing reconstructive dentistry for the first 10 years of my career. Then I pivoted to kind of growth development, early intervention. Then after that, I realized, oh, there's more to the puzzle. Then there's the whole thing that exists as orofacial myofunctional therapy. It's beneficial for everyone, not just kids. So I didn't mean to pigeonhole it into children because we do send adults as well. Everyone can benefit from orofacial myofunctional therapy as well as frenum revisions when they're indicated. So now I'm in a place where I recognize that need, and we do send almost every kid we meet to get involved with these nice ladies that you're talking to here first, Carice and Brittany.
Wonderful. Well, let's find out more about our audience, and kudos to everyone joining tonight. I know you don't have to take these courses, and it's a lot of you are just so passionate about airway, and you really help us move our airway health movement forward. So we want to see who you are. So let's go ahead, and the poll came up here, and let's see. Why don't you tell us about your job title, who you are, who we have with us tonight. I am so happy because Zoom allowed for 10 choices this evening with their update. So hopefully we'll get a good feel of who we have with us. And then the second question is if you're new to MYO or if you took MYO courses before, so we can kind of get to know everybody. Okay. Well, we have 100 people almost participating. Here we go. Don't be shy.
This is so cool to see.
I know, right? It's like live time here. So it's a nice mix. We have a lot of OMTs, we have a lot of hygienists, we have dentists, Hello, everybody. Pediatric dentists, dental assistants, other. I'm sorry about that. I know there's a lot of ancillary healthcare professionals, but we value you as well. And then a lot of people are new to MYO, so that's exciting as well. And those who took MYO before, it'll be great because we're going to have time for interactive conversation. So it'll be really nice to bring everyone together. So welcome, everyone. I do have to do, oh, wait, let me do the shared results. Here we go. Okay. Awesome. Thank you all for participating. So I do need to do some disclosures here. The following webinar is provided for educational informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health provider regarding a medical or dental condition. Some other housekeeping items is feel free to use the Q&A section so we can go ahead and answer your questions throughout the program. We will have time for that, so please don't be shy. And also, in order to receive your 2 free CE units via certificate, you must be in attendance for the entire 2-hour program. Those aren't our rules. Those are AGD PACE qualifications. So the Zoom software tracks attendance. So there's really no arguing about it, or it's pretty cut and dry. So we don't even need a survey or a code. We're just going to look at the attendance, and we're going to email you your certificate if we know that you attended the full 2 hours. So please stay with us so we can provide you that service. And let's kick it off to Brittany and Carice. You're going to kick off with your wonderful BROOMS protocol in screening for myofunctional disorders. So take it away, and then we'll come back with Q&A about the BROOMS.
Thank you, Lauren. We are here to present. Brittany and I co-present. It's going to be very interesting, guys, because we're going to be back and forth between slides, but don't worry, we're going to make it work. It's going to be a great presentation. So BROOMS is our wonderful generalized sweeping categorization of how you can figure out if you have a patient that needs myofunctional therapy. Now, why exactly would you, as a dental professional, most of you, I know not everybody's a dental professional, but most of you who are here that answered the poll earlier that are dental professionals, why on earth would you be the person to look to see if somebody needs myofunctional therapy? Well, actually, we are the ideal people for airway. It is the entirety of our work area. And nobody would ever think that, right? When you think breathing, you think airway, you're thinking, okay, nose, lungs. Like, what does that have to do with me? I do teeth, I may look at a tongue, but I have nothing to do with the airway. When in actuality, you have everything to do with the airway. Let's just start with the maxilla. The maxilla, being the roof of the mouth, is actually the floor of the nose. And so if you're thinking about the nasal floor, I mean, obviously we want a lot of volume there. So when we have a vaulted, narrow palate, well, what are you really looking at? Potentially a really narrow nasal floor. Well, what do you think that patient breathes like? Do they breathe optimally through a more narrow nasal floor? Interesting. I wonder what their nostrils look like, but let's just stay in our work area because the palate is a really good indicator. But let's say you're not looking at their palate. You just ask them to open big, and maybe you're glancing back into the oral cavity and you're trying to look in the back there and try to see, okay, what do their tonsils look like? Maybe, is there anything going on? Tonsil stones, perhaps. You're actually visualizing the whole oropharynx, like you're in the airway, hopefully. If you cannot see their oropharynx, if you can't see their tonsils, you can't see their uvula, you're struggling and that tongue is in your way or that soft palate is low. If you can't visualize their oropharynx, they're probably not able to optimally open and use that oropharynx. Interesting how just a look into the back of the mouth has already given us so many clues. Okay, so we started with the maxilla, then the oral cavity, but what about the mandible? The mandible is actually the anterior and lateral borders of the airway. Can you imagine that? So when we talk about, in just a little bit, Brittany's actually going to talk about bruxism and how moving the mandible is actually going to give you a little bit more air. It's so interesting to think that when we see people who come in with retruded mandibles, see, this is all stuff that we're looking at every day, right? Narrow palates, oropharynx, mandibles that are retruded. When you're looking at someone with a retruded mandible, if the mandible is the anterior and lateral borders of that upper respiratory tract, well, what do you think is happening if it's pushed back? That might mean a compromised airway. We won't really know. So it's a wonderful way for us to be able to take a view of the entirety of the airway by just looking at the things we look at every single day. So through Brooms, we're going to give you 6 wonderful different clues that you can look into, and we're going to talk through each one of them. But absolutely know that you are the key person to be talking about airway and to be observing it. Take it away, Brittany.
All right, so our first clue, B for bruxism, are occlusal wear. So you're in the mouth, you're looking at those teeth, you're seeing those worn edges. This is something you're going to mark, something you're going to ask your patients. Do you clench and grind? Do you clench and grind at night? Do you do it during the day? Is there any tenderness in those muscles of mastication? Do you wake up with headaches and sore muscles? You want to look if there's any tori present, any maxillary mandibular tori. That could be a sign that there's some extreme clenching going on. And like Carrie said, what they're finding through research is that bruxism, clenching and grinding, can really be a compensatory mechanism to try to open that airway. Dr. Gerald Simmons, this thing is flipped. We'll get that fixed for you guys. Dr. Gerald Simmons, who is a sleep physician, he did a study with Dr. Pren. I hope I'm saying his name right, or Preen. I'm not sure how to say it, but another wonderful dentist. And they concluded that bruxism, think about what's going on when you're clenching and grinding those teeth and you're moving around and that jaw is getting put in a different position. Those masseter muscles are becoming activated. These muscles are also responsible for bringing that lower jaw forward. So think about if you're an airway dentist and you're doing sleep appliances for patients, those mandibular advancement appliances are literally doing just that. They're advancing that mandible. So what we're finding, again, is that clenching and grinding is something that we absolutely want to focus on. And before ever making any kind of traditional night guard, which again is very popular in general practices, easy production. However, we want to always rule out airway before we're ever putting patients in these types of appliances. So recommending that sleep study, getting that sleep study, seeing if there's any kind of diagnosis, because sometimes those appliances, like traditional NTIs, can actually make the airway worse. So we don't just want to literally slap a Band-Aid on the problem or just assume that, they're clenching or grinding because they're stressed. Yes, stress does play a role in it, but we really want to think about that whole nervous system and what is going on. What is that root cause? Why is our body acting this way to try to protect us? Another study done in 2017 showed that myofunctional therapy can be an effective therapeutic strategy regarding the treatment of muscle-facial pain and hypertonia of the chewing and swallowing muscles. All treated patients had a reduction of facial pain and reduced number of bruxism episodes per hour, and in many cases, such episodes disappeared. Next up.
It's the disappearance for me. I love that part. And I don't know, maybe this is a little too casual, but Brittany, when you're working with patients, is that something you commonly find that is something that myofunctional therapy is able to help either relieve or eliminate?
Absolutely. I mean, it's not something that we ever guarantee or promise to our patients, because our goals as myofunctional therapists, again, is working on that overall oral rest posture. But the things that we see happen are absolutely amazing. And that's something that, if a patient comes in and that's their pain point, that's the reason that they're there. This is something that you always want to track the progress of. And, even a couple sessions, 1, 2, 3 sessions of myofunctional therapy, you can already start to hear the reduction in these symptoms. And it's super exciting. Totally a win for, of course, the patient, but even for us as therapists.
Yes. And just to make it just a little bit more conversational, Brittany, I just want to throw in there really quickly about mouth guards. So when we're talking about these night guards, it's even hard for me to say. It's like, we're talking about these night guards. I think a lot of people are under the impression that that's actually how you eliminate bruxing, but that doesn't actually eliminate the bruxism, right?
Absolutely. It's just slapping that Band-Aid on it. I know, I think I told you, Carice, that time that I went in to speak to a pretty big dental office, and I told the hygienist never to recommend a night guard until they screened for airway. And I got like a very deep stare from the dentist, like, what did you just tell my hygienist? Again, we're not saying that every single patient that clenches and grinds their teeth 1,000% has an airway issue. However, I can almost bet a big majority of them do. You just absolutely want to rid of that as the primary concern before recommending any of these. I mean, Carice, how many, God, I don't even recall how many NTIs I've recommended to patients as a hygienist before I became a myofunctional therapist.
Oh, so many. I'm guilty of it too. We're all in that party together. But when you know better, you do better, right?
Yes. And even while we're on the topic of bruxism, before we move on, children that clench and grind their teeth in hygiene school, I learned that this is normal. It is not normal at all whatsoever. Not for anybody, but especially for these kids. What is going on that is causing these kids to clench and grind their teeth? It's not just bruxism that you want to look for in adults, but especially in those children.
Yes, absolutely. Preach. Okay. Moving on to the R, getting away from the B and brooms and moving on to the R, respiration. So respiration, just a fancy way of saying breathing. When we're looking at our patients, sometimes even if we go and approach them to get them from the waiting room, you're going to see them at their most rested. I mean, we do have those anxious patients who probably aren't very rested, but they're facial and oral rest posture is probably going to be at their most calm while they're sitting in that waiting room. And so you're more likely to see, are they a open mouth posture, mouth breathing patient? Are they a nasal breathing patient? What is going on there? It gives you a wonderful opportunity to ask them questions. Perhaps you may have caught them on the day that their allergies are acting up the worst and, you know, they're congested, but most of the time they do actually breathe through their nose. It's a wonderful opportunity to ask the question because remember, you are the key person to be talking about airway with these patients, but the breathing is going to very much be impacted by our tongues. Nobody ever thinks about it, but the tongue, and you know, we'll talk more about tongues a little bit later, but the tongue, I like to consider it, and it's just me, I like to consider it a respiratory organ, okay? Because we really need that tongue to be up, lightly suction from the incisive papilla all the way back to that soft palate. And so when that tongue is up there, you're stimulating that nasal floor. Remember that maxilla, that's our nasal floor. We're stimulating that nasal floor. We're also making sure that we're stimulating the vagus nerve. What's the vagus nerve responsible for? Our autonomic nervous system, that fight or flight, rest or digest. We want to make sure that we're utilizing that tongue appropriately. So it has multifaceted impacts. Yes, it's going to help with the respiration, but we definitely want to make sure that we're getting those big, broad arches too, because that nasal floor, we need that. So when you're listening to your patients, a lot of times when I would be sitting a patient down and I'm going through medical history, maybe I'm taking their blood pressure, you could hear them breathing. And that was something that was always very interesting for me. Like, how come I hear you breathing? Breathing should actually be silent. You shouldn't be able to hear anyone breathe. If you are hearing them breathe, let's just stop for a second and think about what exactly you're hearing. You're hearing the sound of air meeting some form of resistance. Potentially, in the case of snoring, it's the tissue vibrating as the air is trying to pass through. But even if you're hearing them just breathe, there's some resistance there. And I don't know about you guys, but there's never a point in time in my life where I would like air to meet resistance as it's trying to come into my body. Because we can go for weeks without food, we could go for days without water, but not many of us can go for very long without, probably just minutes without air. And so anytime you're hearing that audible breathing, anytime you're looking at an open mouth posture, if that mouth is open, that tongue is most likely low, we know we're having issues. And that is a good sign that it's time to send them to a myofunctional therapist.
Grace, you made a good point. Definitely making sure to examine them even before you call their name, because catching them in their natural environment, especially for us as myofunctional therapists, most people have somewhat of an idea as to why they're coming to see us. And I don't know about you, Grace, but I've had parents like literally say to their children, sit up straight or keep your mouth closed. It's like, no, I want them to do what's natural for them, not what we should be doing. That's why they're here. So really trying to catch them in that natural environment, even as you're walking them back to your operatory, seeing, again, is that mouth open? How are they breathing? That posture? Do they have that forward head posture? There's so much that you can observe before you even look inside their mouth.
Yeah, and none of that has to take any chair time away, because I know hygiene, we are busy. Like, we have things to do. We are on a ticking time, and these are quick little things you can pick up on. Do we want to touch on this? Angles,
Yeah.
7?
Let's do it. So a lot of people think that all these concepts, myofunctional therapy is something new, and it's not. It's been in the literature for over a century. So dating back to 1907, when Dr. Edward Engel published The Malocclusions of the Teeth, he literally talked about what these negative oral habits can do, what mouth breathing can do to the stability of any kind of orthodontic treatment, and essentially said that if you do not remediate these poor patterns, we are going to see relapse essentially. So even back then they were, noting what the oral facial muscles did. I think it was Dr. Alfred Rogers that termed the oral facial muscles living orthodontic appliances. I mean, hello, if that doesn't say enough and put an emphasis on the importance of this soft tissue function or dysfunction, they were talking about it back then. So this is not anything new. And then even in, was it the 1940s or 1950s that the first myofunctional therapy program came about?
Yes.
All right, guys, we are cruising. We are moving on to the first O in brooms, orally defensive. All of my hygienists right now are going to be nodding their head without a doubt, even our dentists, battling essentially the patient's mouth. So you're trying to retract and that cheek is like, not having it. You're trying to scale those lower anteriors and you literally have to get up out of your seat, grip those feet into the ground, try to pull that lower lip down and fulcrum anywhere that you can to gain some traction there, because it's so hard. That lip is attached to them. They do not want you moving anything, or that dental mirror is in there and that tongue is literally everywhere that you want to be. It is a pain in the butt. Those are the patients that you see them in your schedule and you're like, oh no, unfortunately, but we can help them. There could be a reason for this. It could be a way that they are trying to protect themselves. Our gag reflex patients, those patients, again, that you're rolling your eyes that, they're due for a full set of x-rays because it's like, oh, this is going to take me forever. Where's the baby sensor? There's a reason for that gag reflex. So not only do we want to note that, but we can even help address that gag reflex as myofunctional therapists. We can help desensitize that gag reflex through myofunctional therapy. So there's a reason for these patients being orally defensive. And this is something, when I learned this, I was like, oh, there's a reason for it. Oh, okay. Now I have to kind of feel bad for them and not be like, oh, why are they in my schedule today? But I know everybody here that is in the dental community absolutely knows at least one, if not a dozen upon dozen of patients that are orally defensive.
The second O is open mouth posture. We touched on it a little bit with respiration. Respiration can be a multitude of things though, but the open mouth posture is very, very much a telltale sign. You'll be able to see this significantly throughout the duration of your appointment. So yes, there's a good bit of time where you're going to have them open their mouth intentionally, but anytime that they're at rest, anytime they get an opportunity to close their lips, are the lips, when they close, pursing together? Do you see tension in that mentalis? For those of you who are not familiar, that's the muscle on top of your chin. Are you noticing that their lip, the lower lip, may be a little bit out and rolled forward? Are their lips very dry? Are they frequently, licking their lips? Are they biting their lips? Do you see them doing that a lot? Is that a habit for them? What's going on with their open mouth posture? All of these are nice telltale signs. But the open mouth in and of itself, that Napoleon Dynamite picture there is like super critical, because what's his real name? John something.
I don't even know his real name.
He's a
I just
handsome
know
guy
that
now.
Napoleon Dynamite.
He's a handsome guy now, but back then, oh man, every time that he had to do like the model lips, I guess, because I don't think that was his actual rest posture, but his lips were always open. And so anybody that comes into your office that looks like a model with like that
Lip.
gaping lip.
Kristen Stewart, she's another celebrity that I feel like is famous for that pouty open mouth posture.
Yes, I don't even know why that's a thing, because technically it's not very attractive, and some people have the teeth to back that up.
And something too that you want to note when you're discussing open mouth posture with patients, nobody really wants to admit to it because they're literally thinking about this Napoleon Dynamite picture. They're thinking that you're saying that they're sitting there with their mouth open catching flies, which they very well could be, but it doesn't have to be open. Like, I don't even know how far this is open. It's like, I don't know, 9 millimeters. It's pretty far open. Really, anything other than that competent lip seal is open mouth posture. So if you are seeing the teeth at all, that lip seal is still broken.
Yeah. And sometimes just drawing their attention to it might be enough to just put in a little bit of a spark there that may eventually, when they come for their next appointment, they'd be like, you know what, I did notice that my mouth is open often and I have difficulty closing it. What can I do about that? Now you know.
Moving on to the M in Broom's maxillary transverse width. So Carice gave us a beautiful depiction of the whole airway component that we are working with, the maxilla being that first one that she was referring to, the importance of making sure that we have proper growth of the maxilla. The tongue resting up in the roof of the mouth is going to help provide that stability, those proper forces to have that bone loading to really grow the maxilla and the mandible appropriately. But just take a peek. Is there crowding? Are you seeing that nice U-shaped arch like in this first picture? Or are you seeing more of that V-shape arch? Or even possibly that omega shape arch? And something easy that you guys can do, everybody has a cotton roll on their tray. Grab the cotton roll, make sure you measure it. They generally are all 37 millimeters, but you want to make sure you're going to stick that up between 3 and 14. And if you're shoving that cotton roll in there, then you know that their maxillary width is not adequate. Really, we want to be about between 40 and 44 millimeters from number 3 to 14. And unfortunately, there's not a lot of us walking around there with adequate maxillas. Carice is definitely a unicorn. She has a beautiful wide smile. Something that you can tell when Carice smiles is you don't see, like you do in my smile, excess vestibular space. So she does not have those dark buccal corridors when she smiles, because her smile, that maxillary arch, is really taking up its entirety. If you're seeing this crowding, that V-shaped arch, that omega-shaped arch, do you really think that the tongue is going to be able to fit in there? Oftentimes we hear patients say, oh my gosh, my tongue is too big. It's not that their tongue is too big for their mouth. It's that their mouth is too small for their tongue. Sorry, I thought I was going to get that wrong. Great book by Dr. Felix Liao, 6-foot tiger, 3-foot cage. Kind of makes that analogy. How would a 6-foot tiger ever fit in a 3-foot cage? Same idea. You can even look at, and you can tell in these pictures here, that these incisive papilla are pretty prominent. So, I'm sorry, the incisive, the palatal rugae there, those rugae should really be worn down from the tongue resting up in the roof of the mouth. When the tongue's not resting up in the roof of the mouth, it would make sense that these rugae would then be prominent. And a lot of you might be saying, well, how am I going to know if rugae are prominent or not? Now that we told you to look for that as a sign, think about how many rugae you see a day. You're going to very easily pick out which are prominent and which aren't. That tongue with that arch, the two are not going to go together. That tongue is not going to fit up in the roof of these mouths in these two side pictures. There's just not enough real estate up there. And then we want to think about also what Carice was speaking about, The jaw is also the floor of the nose, the lateral chambers of that nasal cavity. So how do we think that that's going to impact us nasally? How well are we going to breathe when our jaw is so narrow? What is that going to reflect in our nasal cavity?
It's a wonderful callback to anatomy. And I don't know how many people enjoyed anatomy. I certainly didn't, but it is a callback to anatomy. Mentalis. A lot of times we may see that dimpling on that muscle with right by the chin. So it gets overworked. A lot of times some people are using it to help them with the swallow. So when the tongue is not doing a wonderful wave-like peristaltic swallow during the oral phase, then we have some sort of compensation where the tongue is doing another move. It might be a thrust or something else. But then the facial muscles have to incorporate and engage as well. And oftentimes that poor mentalis gets called for duty. So I don't know if any of you have like a coworker that doesn't always show up and then everybody has more work. That's the mentalis. The mentalis is like, why aren't you showing up, tongue? Like, I don't want to do your job anymore. And so it gets really, really tight and tense. Imagine a clenched fist, right? It's an overworked muscle. So if you were to do a whole lot of bicep curls and you did nothing but bicep curls and you really developed like Popeye biceps, right? It would look really strange with everything else around it if you haven't been working on your forearms or your triceps, or you haven't been working on anything else. And that's what the mentalis looks like when it's super bunched and very prominent. Sometimes it looks a little dimpled. And a lot of times with the swallow, if it's happening during the swallow, there might be some incompetence of the lips. You might note that for this one, you're saying, yes, they do have open mouth posture. Yes, they do have a strained mentalis, because the mentalis has to be recruited also if they're trying to forcibly close those lips to do a swallow, or to just maintain a closed lip posture so that they can fake it long enough so that you stop asking them about their open mouth posture. And so strained mentalis, big telltale sign. If you've never seen like a bunching of a mentalis, just imagine if you look at like in orange and how it's got like stippling in it, the mentalis muscle would look like that. It would be very prominent.
And that is it. That is our 6 clues. So this is a copy of our screener. So if you check 2 or more in that yes column, that is an automatic referral to the myofunctional therapist, something that can very easily be integrated in your hygiene appointment, in your EOE, IOE. Again, very simple. And then we do have just 2 more bonus slides, Lauren. I saw you hop on there, but
okay, I
did want to add a little bit of bonus because I know everybody's going to say, well, what about tongue tie? Why didn't you include tongue tie in that? Yes, tongue tie is very important. However, the reason Carice and I did not include it in our broom screener is because tongue tie is not something that you can assess or diagnose very quickly. You need to have a full functional evaluation by a myofunctional therapist to really know, is that tongue really tied? Are there functional implications? But of course, we want to know certain little signs and things that we can look for to know if we need to send somebody off to that evaluation with a myofunctional therapist. So that is the bonus that we are going to provide for you. Assessing for tongue range of motion. You can get these, let me grab one for you guys, these little range of motion rulers if you want in your office, but you don't have to. In these 2 videos, you are going to hear me ask these children to open to their maximum. And then I'm going to ask them to elevate the tip of their tongue behind their front teeth. Now, my instruction to them is to open and elevate their tongue without closing. I don't care if your tongue touches the roof of your mouth. I just want you to try to elevate it as best as you can while staying open. That will then tell me how much farther they have to go to the roof of the mouth to know if they're restricted. Or what you'll see in the second video I'm going to show you is that that little boy completely closes his jaw in order to get the tongue up there. Either way, you're going to see the restriction in both of these patients. You can. Big. And then I want you to stay open that big, but I want you to try to touch the top of your mouth with your tongue. So see how she's got another like 30-ish, 40% to go. And then she eventually closes so that her tongue can reach. And then you can see here, which I actually have a picture of, but we're going to show you this little Eiffel Tower attachment at the base there. And then in this young boy, he is going to close his mouth in order to get the tongue to reach to the roof.
And big. I want you to try to bring your tongue up to the top.
He had a pretty
And
significant tie. I'm sure you
open.
all were able to see that as he was elevating, but look how much he had to close
And
in
bring that
order
tongue
to
back
get the
up.
tongue up there. So those are quick range of motion tests that you can do. You don't have to just target them right behind the teeth. You don't have to get exact
You
with like,
can.
put it on the incisive papilla, even though that's where we want them to put it. Here is that picture of the same little girl, but her Eiffel Tower attachment here. You can see how it's the frenum, straight, and then it kind of flares out on the edges, attaches to this alveolar ridge instead of into the floor of the mouth. Oftentimes when you see this Eiffel Tower presentation, it is associated with a posterior lingual tie. So something to take note of. As Carice mentioned, that tongue, it's a respiratory organ, it's a muscular organ. It is responsible for so much optimal craniofacial growth and development, optimal development of the respiratory complex, mastication, the way we eat, chew, swallow, speak, keeping that upper airway open. When we talk about the functions of the tongue and you're assessing for tongue tie, just asking somebody to stick their tongue out is not enough. And really, this is what we learn in hygiene school, in dental school. If somebody can stick their tongue out past their lower lip, then there's no way that they're tongue tied. And I can tell you right now that that's not true. We have lots of patients, Carice, I'm sure you would agree, that can bring their tongue down to their chin, curl it up to their nose, but still have a posterior tongue tie. Protrusion is one function of the tongue. The tongue needs to be able to lateralize side to side, right? To bring food side to side. Our tongue needs to be able to cup and create almost like a bowl to accept food, to receive food. We need to be able to, of course, elevate our tongue, not just the tip of our tongue, but the tip, middle, and back of the tongue, like Carice spoke about for that peristaltic motion of the tongue in our swallow. And also just for correct oral rest posture, that posterior portion of the tongue needs to be engaged in the roof of the mouth. We also want to have the ability to dissociate our movements between our tongue, our jaw, and our lips. So we call it mandibular differentiation. This is something that we're looking for and that we're working on with our patients. We're guiding them to do certain excursions with their tongue while keeping that jaw nice and still. So you can see how it's a little bit more complex to do like a full functional evaluation of a tongue tie, but these are just little tips and tricks for you guys to try to take a peek of and jot down some notes to know when to make that referral. If you're working in a practice that, your hygienist and the dentist is doing tethered oral tissue releases, or you're noticing this tongue tie, you want to make sure that they do get to that myofunctional therapist first, again, to have that proper evaluation, but also pre-operative therapy is key. Most people can understand why they would need to receive some kind of therapy after a tongue tie release, right? We want to make sure everything heals okay. We want to make sure we increase range of motion, but sometimes they're a little confused as to why they need to see a myofunctional therapist before. We want to work on any compensatory movements, any compensatory muscle involvement that is going on and try to optimize that function. We want to optimize that range of motion. We want to educate the patients and we want to be there to support them, make sure that they get to the proper providers that are going to do a good job releasing this tie. We also want to make sure that families are prepared to do their postoperative stretches. Depending on the age of the child, the parent is going to have to assist in these stretches. And you really don't want the first time that you're doing that to be when there's an open wound inside the mouth. So we really want to make sure that we're preparing our patients enough. We want to ensure that we're helping to release any fascial restriction that might be presenting, in the areas. Some people say that, we're going to do the myofunctional therapy before so that we can try to stretch the frenum. The frenum isn't going to stretch the type of collagen that it's made of. It's not elastic. However, when we're working through some of that fascial restriction, we can see an increase in that range of motion and that's what makes people believe that we're stretching the frenum. But unfortunately, we cannot do that. Post-operatively, we want to make sure that we're providing active wound management. This would have already been reviewed in pre-op, so they are ready, they are confident to tackle this. We want to help promote optimal healing, prevent reattachment, prevent any scarring from occurring. And then after that, once we get through that active wound management phase, that's where we continue back into our myofunctional therapy program, optimizing that function, repatterning those muscles so that we can reach our overarching goal as a myofunctional therapist, which is to restore proper oral rest posture. So again, a tongue tie is only a tongue tie if function is impacted. And that's why we want to make sure that we refer to a myofunctional therapist. All righty.
Okay, well, that was wonderful. And actually, we have Dr. Boyd with us tonight who commented. If you just check his comments a little bit, one I answered, so it's not showing up in the Q&As, but it's a very good point that I want to share. It's that normal literally means average. Pediatric bruxism is nearly a universal trait in kids under 6. Therefore, it is considered normal for this particular segment of the population, but it is not optimal, as you two, this is from his words, understand, but not appreciated by most dental professionals. Then he gave you kudos of doing a magnificent job tonight and clearly conveying these important normal misunderstandings. So thank you, Dr. Boyd, for that insight. And in fact, if you wanted to come off mute, Dr. Boyd, you could. If you wanted to chime in with your expertise, we would love for you to do so, but no pressure. And then there was another question. Let me go to the open questions. If a patient is bruxing and goes for a sleep study, an OSA is confirmed. If a CPAP is recommended, does this alone prevent a person from grinding? And before you answer that, I just want to let you know we did put in the chat 3 talks with Dr. Gerald Simmons that goes over all of this in tremendous detail. So I know it's not the subject of our talk tonight, but there's so much to learn, and we put up those resources for you to watch and share. So did you guys want to touch on that? Or Dr. Morale, you want to come off mute also and come on camera? You can all just maybe help Sarah with that question. Want me to repeat the question?
Sure.
Yes.
If a patient is bruxing and goes for a sleep study and OSA is confirmed, if a CPAP is recommended, does this alone prevent a person from grinding?
So Dr. Simmons covers that pretty well. In fact, it's part of the research that goes to show the impact of better airflow. So in his PSG studies and research, what was shown was that a patient who is actively bruxing throughout the night, when they are placed on CPAP and it's titrated perfectly, it'll shut down that whole mechanism. So all of the musculature will stop. So then you remain with the positive airflow through your CPAP and at just the right level. Yeah, you're not supposed to be bruxing. So the outcome of having a CPAP isn't just, oh, you got your OSA diagnosis, let me take this machine home and strap this on my face and wear it, because that doesn't actually prove it's set correctly. So you actually have to go back through another sleep study with it, because there are different kinds of masks. Then there are different kinds of straps. Some of them go around the head. Some of them come up over the top like a little cap. There's nasal, there's oral, there's both. So you really have to go back and do follow-up to know, did it shut down the sympathetic nervous system? Because the entire reason for wearing that isn't necessarily the only objective to take away the apnea or the pause. It's to basically regulate the entirety of your system right down to the cardiovascular changes. That's really where the damage occurs. So OSA has 2 outcomes if it's untreated. The top 2 problems are a heart attack or a stroke. And so there's a long list. There's a long list of symptoms and medical damage happening from OSA. But at the top of the list, the 2 outcomes that we're heading towards are the stroke and heart attack. So if you're going to get a CPAP, then you really want to go back and have the follow-up to know that it's doing exactly what it was supposed to do, and I have the credentials to show for it in a sleep study. Yeah, that would be important.
And
Right.
myofunctional therapy is a patient that is going through CPAP therapy. You still can do myofunctional therapy with. They still can benefit, can make wearing the CPAP much more comfortable. There's a study done by Dr. Camacho in 2015 that shows that myofunctional therapy can help reduce the AHI 50% in adults and 62% in children. So you don't want to rule out, just hand that CPAP over. They should still get to a myofunctional therapist to really aid and work on those pharyngeal muscles.
Dr. Boyd also asked, what about kids without erupted 6-year-old molars yet? How would you determine maxillary transverse deficiency in the primary dentition in the absence of a posterior crossbite?
Then we would measure between A and J. And so the upper molars that are back there are lettered A and J, and you measure between A and J. And that dates back to Dr. Edward Bogue, and it's called the Bogue Index. But Dr. Bogue did this 100 years ago, and I was actually taught this by Dr. Kevin Boyd. Dr. Kevin Boyd is one of my early mentors, and I learned it from him. And he introduced me to this because I had learned about the Dr. McNamara measurements later, which are permanent teeth or mixed dentition forward. So I learned 3 to 14 first, then worked my way back when I had met Dr. Boyd. So measuring between A and J at age 3 is a very good indicator, because Dr. Bogue's research showed a child needs to be at about 30 millimeters at age 3 to 4 years old in order to develop a healthy occlusion with all teeth present and little to no crowding. But he knew that 29, 28, those numbers are insufficient, and that child is going to have crowded teeth. And the lower the number is at age 4, the worse the crowding is going to be later. And it's interesting that a lot of us are aware of some of the things downstream from Dr. Bogue's research, but we just don't remember his name and learning it in our dental professional, studies. But we remember the part about if baby teeth have no spaces, the permanent teeth are going to be crowded, they're going to be bad. We all talk about that, and it's kind of universally known in the dental profession. When there's no primary spacing, big crowding is coming. That is the result of Dr. Bogue's research. Dr. Bogue's research showed that if you're narrow and the teeth are together, primary teeth, here comes the big crowding. So we kind of know it, we just didn't remember the specifics, but that's where it comes from, Dr. Bogue.
Does a lip tie also affect airway?
A lip tie can affect airway. It depends on if that lip tie is functionally restrictive. So is it inhibiting the patient to be able to close their lips and to maintain a lip seal? That's when it becomes a functional problem, not just a cosmetic one with the potential for a diastema, but like function, being able to sustain that lip seal. That way you can facilitate nasal breathing.
And do we know if tongue ties are strongly associated with small mouths, oral volume, or were they probably present pre-industrial as well with well-developed jaws?
So it turns out that having a restricted tongue mobility is a risk factor for underdeveloped jaws. So yeah, there are pathways to having underdeveloped jaws, crowded teeth. One of them would be the early soft diet. So the early soft diet basically delivers weaker musculature. So weaker muscles, they don't have to work as hard, don't grow bone as well. So early soft diet, weaker muscles, smaller growth in the jaws. That's a pathway. The other pathway would be restrictions. And so the lingual frenum restriction would be one, because if the tongue can't go to its place properly, it's not going to be able to have an effect on the bone growth. So you have early soft diet followed by tongue restriction as being risk factors for growth and development in the jaws, certainly.
Great. So those are all the questions, but thank you, Dr. Saunders, for your comments on that. These are basics that are mainstream, and doctors and hygienists really need to address more actively in their practices. All too often the OMT angle is absent, and parents really need to know to ask about it and choose dental practices accordingly. Thank you for presenting these groundbreaking principles. So thank you, Dr. Saunders, for your comments. And so let's go then with the next portion of our presentation. And I love actually seeing the cases. This is what compelled me in the beginning to be involved with airway, was a couple of these cases that I've seen. And Dr. Ben, why don't you go ahead, share your screen, and let's put this all into a clinical perspective of how important myofunctional therapy is in your coursework.
All right, let's see here if I get my choices right. Is that our title slide ready to go? Did everybody?
There we go.
Is it up there? Okay.
It's up there.
All right, here we go. All right, so those two are a tough act to follow. This is uncomfortable going second after that presentation. Yikes. I don't know if I can deliver at that level. That was special. Thank you very much. So here we go. So these cases we're going to share here are going to be similar in a few things. The first will be that they'll all have, of course, myofunctional therapy involved. Then they'll all have frenum revision involved. And then thirdly, they'll all have expansive and or growth and development type orthopedic orthodontic techniques. So the 20 years I mentioned in the intro has been basically me only doing non-extraction growth and development techniques from the age of 3 on. And so we're always looking to go wider and forward. We are looking to develop the foundation first, then the teeth second. So the underlying philosophy would be foundation first, teeth second, and then of course inserting the different components that make up collaborative care so that we could really help a child heal and also have a beautiful smile. So it's nice to have straight teeth. Everybody wants to look good, no problem. But it's really not about the teeth. And so to have a tooth-focused approach would have a different outcome. And one of the other kind of commonalities in these cases is that they all did have a kind of beginnings with a tooth-focused approach, and we can see where they are there. And then what if we go ahead and retreat, so to speak, with foundation first and then tooth-focused second? So we're going to look at this patient, Lauren. So we meet Lauren at age 14, and she has a long history, which begins really around age 3. And so OSA, obstructive sleep apnea, she'll have that diagnosis in there, headaches, narcolepsy, anxiety, depression, ADHD, insomnia, and she is a failed CPAP user. Her OSA was mild to moderate as a kid, and so they tried CPAP, that failed. Narcolepsy is you can fall asleep anywhere at any moment. Insomnia is you can't sleep when you're at night. And then, of course, if you take a full history back to age 3, there were digestive issues as well. And digestive issues, in her case, go all the way to having endoscopies to figure out what's happening on the inside. So she's been through a lot from age 3 to 14. So we meet her at age 14. And so we'll take photos. And of course, you know, the reference earlier was about having a tooth-focused approach versus having a foundation-focused approach. So that's why the title has after and before, because this would be considered an after picture because she has had 2 years of braces to get to this point, but that's somewhere else. So when she shows up to meet us, I'm taking my before picture because we're just getting started in treating her with our foundation approach. So you can see a smile here. The front teeth are straight. But when we look here, a lot of the things that we heard from Carice and Brittany about the narrow smile line, the open or dark buccal corridors, she is front tooth prominent. And by the canine, we barely notice them. There's slivers, and we go all the way back and don't see any back teeth. So we'll know from a photograph like this that she's pretty narrow. Then the profile, of course, will start recognizing a lot of the things that Brittany and Carice presented, in that there's going to be a lot of soft tissue dysfunction. So generally, I'll be saying soft tissue dysfunction. When a nice girl, Lauren, like this gets to see Brittany and Carice, then of course they will determine where all of the muscle dysfunction is coming from and then help treat it. So she's going to end up there as well. So we can get a little closer and start to recognize that, yep, perfectly straight teeth, narrow, everybody leaning in. And of course, you know, we're looking for something more than this. This is the picture that we really like to focus on. So this happens to be one of my favorite photos in any case. We just take this photo on purpose, because when you take this picture, open up a little bit and just let your tongue relax for a moment. This is a good photograph to have, because this is exactly what we just heard a moment ago, the perspective of what's going on. You know, this is not a big tongue. This is an absolutely average sized tongue, but the jaws are undersized and the teeth are really close to the tongue. And so all of a sudden you start thinking about, where could that tongue possibly be when she closes her teeth together? And so when this nice young girl closes her teeth together, that tongue has nowhere to go but back. And the fancy words, when you're reading the research, it says posterior displacement of the tongue. Well, posterior displacement of the tongue is the wording that you find in the sleep research, because having obstruction comes from the tongue being too far back. So posterior displacement is obviously leading to the air blockage, and a good reason why she would have obstructive sleep apnea as a diagnosis as a child. So all of a sudden, we take a look at this picture, we take it for all our patients. It's not a bad idea to get into a habit of this. Then you start recognizing, well, there's an issue here, and you should first of all have a good perspective of this. This is not the right size home and the wrong size tongue. That's not a good perspective of this photograph. The proper perspective of this photograph is, this is the right size tongue in a garage that is too small. So you start thinking about how important the tongue is for all of the things it's supposed to be doing. Breathing is really at the top of the list. And when we think about breathing, so my reference for the tongue would be, it really is your body's Ferrari. So the tongue is your body's Ferrari, and a Ferrari would deserve the appropriate parking garage. This is not a parking garage for a Ferrari. This is a parking garage for like a tiny little scooter. So we need to make the garage bigger so the tongue has a place to land appropriately so we could breathe better. So this is a good photograph to start taking, get your perspective straight, and then recognize if this patient's showing up with breathing problems, you would have a good reason why here. If they show up and you take this picture, then you want to pursue the sleeping breathing pathway and maybe then ask for other things to learn about it. On the side of the tongue, very clear scalloping, and a scalloped tongue is in the list. It is a risk factor for sleep disorder breathing and or obstructive sleep apnea. Obviously, when the air is trying to get behind the tongue is going to press forward. So whenever the mouth is in a closed position, the tongue is going to be forced forward to let the air go. When the tongue is forced forward, it starts making imprints on the teeth. And that's how much the tongue is forced into the teeth, is it starts to develop the imprints of the teeth on the side. So we've got all this working for us here. Then we start taking these pictures, which was just covered very nicely. And of course, we'll start taking pictures. Okay, elevate your tongue towards the roof of your mouth to see, what does the frenum look like? How does it, perform? Where is the function? And for me, I draw the line short and we say, oh, it is time to go to orofacial myofunctional therapy. And we throw those words out. Most parents don't know what that is. And so we say, yep, they're very long words, but orofacial myofunctional therapy, we try to kind of reduce it for parents and say it's a lot of fancy words, but don't be alarmed. It really is physical therapy for the head and neck. So the tongue plus the head and neck, we're really talking about all the musculature that is involved in mastication, et cetera. So orofacial myofunctional therapy, when we start sending the patients, we talk about, it's about breathing, it's about musculature, it's about posture. There's a lot going on in here to kind of reset your child. So we recognize this frenum is a potential problem. We want to make our referral because we know already if this is how the child has grown and developed, they have soft tissue dysfunction. And then the possibility of the frenum being too tight, we're going to leave that for Carice and Brittany to make the full diagnosis and make the referral. So when we go here to our photographs, we know we've got this starting point. Then we'll take a picture like this and we'll know, okay, it's attached to the ridge. Now it's attached to the ridge. We could see the little bit of the lingual bar showing there. We know this is post-ortho. So again, we're taking a look at this patient from two perspectives. One is, these are my before photographs. We're just meeting her at age 14. We want to go obviously and treat this child. So we call these before photos, but she's 14 years old, has just finished 2 years in braces. So having had a 2-year in bracket and wire technique, her teeth are straight, but her arch is underdeveloped. So the transverse measurement that was just introduced so nicely, in between T3 and 14, this nice child measures 29 millimeters. So a moment ago, we got introduced to the cotton roll being 37 millimeters and how the 37 millimeters would be appropriate for, a teenager to have at this point as a minimum almost. We think about the 29 marker. That's a really good marker because 29 isn't really good enough for a 4-year-old. So we would want to have A and J in the primary teeth at age 4. We're supposed to be about 30 as a minimum. So 28 and 29s, those are bad numbers when we're 4. It's not a good size of the maxilla to have 29 millimeters between 3 and 14. So now we recognize she's very narrow and then very underdeveloped in the jaws, more so than the teeth. So we're going to have these narrow arches to deal with. So now we take a look at our next photo. Let's see here. There we go. So the lingual bar was placed, 2 years in brackets and wires, straight teeth, lingual bar, but we're narrow. So we're going to have to pursue a slightly different pathway. Now, when taking the whole history, it turns out since we ask questions along the lines of sleeping and breathing, it turns out she has had her CPAP, so we want to know about what was your sleep study results. And here they are. So respiratory disturbance index, RDI, the number was 65, that's 9.3 per hour. The apnea hypopnea, the AHI 47, that's 6.7 per hour. As a 14-year-old, it falls in the pediatric category. You only need 1 event per hour to get the apnea diagnosis. And these are high enough to push her on the borderline of mild to moderate. So she comes with a diagnosis of mild to moderate obstructive sleep apnea, characterized by elevated indices, restless sleeping, snoring. OSA could account for Lauren's daytime sleepiness, needs to be treated first before considering the possibility of narcolepsy. So she gets a CPAP. She tries the CPAP out. She does have the testing for narcolepsy, which when you go through the narcolepsy testing, I know this is a whole bunch of numbers and times, but the end result is that in the note, you could see that with the note here, Lauren had 4 chances to nap and slept in all 4. Sleep latency was 9 minutes, 7 seconds, but in 3 of the 4 naps, she entered REM sleep. And so basically the napping in 3 of the 4 and entering REM sleep, all of a sudden what happens is you meet criteria for narcolepsy. So she does meet the criteria for narcolepsy. And if she's wearing a CPAP and still has these symptoms, she could achieve a diagnosis of narcolepsy in her history. What it all leads to is that she's being seen by a pediatric pulmonologist. She's being managed in multiple different categories. We saw her kind of medical struggle list on the opening slide, but the last paragraph here kind of details where we're headed. Once again, in assessment, Lauren has at least 1 and in all likelihood 2 distinct organic sleep disturbances, accounting for her excess daytime sleepiness, occasional poor school performance, lateness, and absences. I would ask her school and teachers to be understanding until the situation gets rectified in the next number of months. Basically, all of this was to produce the pathway to help her at school because she needed more time in everything, accommodations in everything. She had difficulty being awake at school. She had difficulty getting to school on time, difficulty, even making the day at school. So the absences. So all of this results in her getting more time in school, delaying everything, more time in testing, more time for projects, et cetera, et cetera, et cetera. Because here she is at 14 years old, struggling, and year after year after year, she's falling further behind. So in falling further behind, all of a sudden what happens is falling further behind at 14, you're going to be heading into high school. So it builds a lot of anxiety in her and the parents in that if she falls behind, the entire pathway could be ruined because people start thinking about, well, you have to perform well in school, then you go to a nice college, and the whole pathway is kind of set in place, and she's not heading in that direction at all. So now we have to treat this nice young girl, and we have a foundation first and teeth second approach. So we're going to use expanders first because we need to kind of grow the bone. Let's make a bigger foundation for her. So we'll take her into fixed expanders. So she's going to have fixed expanders to go from 29 to 38. So what you're looking at here is kind of the day the fixed expander was removed. So it has a little imprint and a little, gum gingivitis showing up there where it's hard to clean around the band. But the idea is what you're looking at is 9 months progress. So 9 months later, with the fixed expanders in there, all of a sudden we have a different vault, a different palate, a broad, wide open maxilla, and we have now achieved a 9 millimeter increase. So we're up to 38 millimeters between 3 and 14. Then we could take a look at the lower arch, and it's had a fixed expander also, because if the upper is going to go 9 millimeters, the lower has to follow it. So there's a fixed lower expander, and that was resting in here and banded on the first molars. And we use that as well for the 9 months, and it develops the entire mandible out to that same measurement. So now we've got a 9 millimeter change. And when we take a look at, all of a sudden, actually on the right side, you can see the tongue kind of sitting in that space a lot easier than what we saw before where it didn't fit. But now we've got this. So we've gone from here to here, and this is just fixed expanders for 9 months. We haven't done anything to the teeth. We've only worked on the foundation. So we've got fixed expanders, 9 months, 9 millimeters change, and now her tongue has a whole lot more room. So all of a sudden, we have a different child. She's starting to heal. So at this point in time, 9 months into treatment, she now starts to sleep through the night. The symptoms start to fade, so she's improving. So her face looks different because she has a bigger maxilla and a bigger mandible. So now her face is more round and more full as opposed to more long and drawn out. And all of a sudden we have better nasal breathing happening. We have better sleeping happening. We have more tongue space. All of this is kind of falling into position. So we're heading in the right direction, but now we've got to do more for her. So you can see here the difference in just the first 9 months. We've got the bigger maxilla and the bigger mandible sitting there for you, plenty of tongue space. We're heading in the right direction. We've got the right foundation. So after having the right foundation, we've got to get ourselves moving along to coordinate the teeth. So we do the teeth second. So part 2, now, of course, when the fixed expanders are in the way, those are not very helpful for the myofunctional therapy part. So I tend to do the fixed expanders first, get the foundation opened up where we need it to be. And the day we remove them, then she's going to head over to the nice folks at CTOM, which you've been hearing from already tonight. So now we're going to get her in clear aligners because, turning 15 or now 15 years old, nobody else has braces on at 15. She doesn't want to be the only one. We'll use clear aligners to finish. So we'll take off the expanders, get these scanned because we're going to make clear aligners, but then immediately we'll refer to CT orofacial myology, where she's going to work with them for many months because we have to do what you heard was prep work. Of course, the diagnostics to determine is there a frenum to release, et cetera, and then have that done in coordination with the rest of it. And it turns out through their diagnostics, they know that the tongue and the upper lip were too tight and needed to be revised. And here we are in New York and Connecticut. So we sent her into the city to Dr. Scott Siegel, who does wonderful revisions. And of course, now this is all collaborative care to help heal this child. So when we add the aligners to the case, we don't go the other direction because the whole object was to do expansive growth and development orthopedics followed by orthodontics. So when the aligners go in, they take over at 38 millimeters. So what you're looking at here is the end of the expanders. We have 38 millimeters. When we use our aligners for the next 12 months, we're going wider. We go to 41. So we take that child again wider. So we're moving out. We're always moving away from the tongue. There aren't really good reasons to move teeth towards the tongue. Bad things happen when you move teeth towards the tongue. So we're trying to move them away. We go from 38 to 41. The lower has to go the same. So the lower is going to get a little wider. And we've just coordinated all of the teeth very nicely so we can be here. So now the picture on the left is after the fixed expanders, which gave you the foundation. The picture on the right is using the clear aligners to just kind of coordinate the teeth and have a beautiful bite again. But then the big difference becomes in the smile line, of course, you have your teeth coordinated nicely and well aligned and occluding nicely. So you go from the picture on the left, which was after expanders, to the picture on the right, which just turns out to be a class photo. So, the class picture shows up very nicely. And, you can see that she's definitely healthier. And we're going to take a look at the entirety of the before and after. So she started out at 29 millimeters as a transverse measurement. After fixed expanders, instantly into the myofunctional therapy with the Frenum revisions, and the myofunctional therapy program was probably somewhere between 6 and 9 months. Then, of course, we get the clear aligners to finish the job and get to 41. So 29 to 41. The lower will follow suit. So we're going to get our same thing all the way out. We end up with a beautiful bite, coordinated teeth that don't require anything other than the fixed expanders for the foundation, the clear aligners for the bite. And here's the before and after, the beginning where she came in and had her 29 millimeters deficiency in the maxilla and mandible, the open buccal corridors. Then, of course, the narrow and underdeveloped jaws lead to all the symptoms where she was struggling with for over a decade. Then at the end, we've got this fully developed human with the proper maxilla and mandible size who can sleep and breathe perfectly. So we go from being unhealthy to healthy. So over the course of this treatment, she fades to healthy. So it's not like a light switch. It's not instant. We don't go one day I'm bad and the next day I'm perfect. It's a slow progression. And don't forget, she's been struggling for more than a decade. When we do the full history, we learn at 3 years old, these problems began. They were struggles at 3. And from 3 to 14, that's an 11-year run of struggling in the medical kind of symptom list with really no solutions. All the treatment there was based on symptoms, and treating the symptoms is different than treating the cause. So here we are working on the underdeveloped jaws. We're talking about the malocclusion to deliver a healthy child. Now, of course, at the end, she's going to repeat a sleep study so we can prove that she's got all zeros here. So all the zeros show up here, and it turns out in the entire nighttime, she has obstructive hypopneas, only 3 events in the whole nighttime. So it's 0.4 per hour. So now she comes down in all these numbers. Most of these are all zeros, and she only has the 3 in the entire night, and she was having multiple per hour before. Then she repeats, everything, the OSA as well as the narcolepsy study. Here's the physician referral form. She's back at 16 years old and a history, anxiety, depression, ADHD, was diagnosed with moderate OSA, narcolepsy without cataplexy. She has morning headaches, daytime somnolence. She used the CPAP previously. But now here we go, the tongue and the lip tie removal, palate expanders at age 15. So now we were ordering to reevaluate for the possibility of sleep apnea and then followed by the narcolepsy evaluation. So through the testing, no significant obstructive sleep apnea. So reassurance to the parent, she does not have OSA. And then she goes back through the multiple sleep latency testing to demonstrate she doesn't have the typical finding seen with narcolepsy. So her multiple sleep latency test, the MSLT, proves now that she does not have a narcolepsy condition to deal with. So we get an email, of course. The parents will send, hey, Dr. Morale, I hope all's well. Attached, find the results of Lauren's recent sleep study. I included the ones from 3 years ago so you can see the difference. Very interesting how she no longer presents with apnea and narcolepsy. So it certainly is interesting how she no longer, because I don't treat apnea, I don't treat narcolepsy, I don't treat insomnia, I don't treat ADHD, I don't treat headaches, I don't treat digestive issues. I don't treat that list. What I treat is underdeveloped jaws. So in my world, the underdeveloped jaws will deliver your breathing problem, and your breathing problem is going to really trigger the sympathetic nervous system. And once you've activated the sympathetic nervous system, you have a really bad combination going on. We have poor breathing, bad oxygen, carbon dioxide, and nitric oxide activity and balance. That combined with changing the cardiovascular system, then our digestive system, all of the things that fail downstream. You've got an 11-year history of this poor girl kind of suffering through everything, but treating in the symptom column really didn't help her at all. And then, of course, you have an example of where, okay, braces could be used to straighten the teeth, but braces offer nothing when it comes to tongue space, sleeping, breathing. Braces are really a tooth-focused approach. So it achieved its goal. Braces can straighten teeth, they did. But when we took a little different approach and went after the foundation first, we end up with a perfectly healthy child. So in conclusion, so this case is being written up for a dental sleep journal right now, but today we're about 2 years post-treatment. Lauren doesn't have or is treated for any of the original diagnoses. No more ADHD, anxiety, depression, insomnia, narcolepsy, OSA, all of it's gone. She has no digestive issues. She has no headaches. She basically now sleeps with nasal breathing that is silent and invisible. She sleeps through the whole night. She wakes up in the morning. She goes to school refreshed. She is the equivalent of a straight A student, has no more extra help, no more extra time, no more tutors. And in fact, recently, she just won in New York State. She just won first place in a science research contest. So here she is doing research now. What she chose to do, which was a surprise to me, she kind of surprised us at the end. She chose to do with, I think it was the tsetse flies. It was a particular type of fly that has a sleep pattern at night. And what she did was she was shining lights on them in the middle of the night. So every so many hours, she would wake them up and pretend it's daytime, right? So they would all wake up. Then she would turn the light off. She basically disrupted their routine overnight to show that the group that doesn't get disrupted at night, those flies, they have a certain amount of activity during the day. So she could document, what does that fly do during the day? These are, it's, activities. Then when you disrupt the fly sleeping at night, it won't perform the activities during the day. So she ended up showing in a fly model that ruining the sleep of a fly changes its behavior during the day. It is now an unhealthy organism. So she ended up winning first place in New York State in a science project and then shared that with us. It was a phenomenal thing to see her do with the board and everything. It's really nice. All right, moving on to Christopher, age 9.
But I'm sorry, just gonna interrupt real quick because there's a question specific on this case that I thought would just be helpful.
Sure.
Rather than go back.
Yeah.
How were you able to get from 29 millimeters to 41 on the one child? Where did she end in the fixed expanders and how much did you gain from the aligners?
Right. So let me go back to those photos because it was in here. Okay, so I can show the pictures right here. So this is the fixed expander. The fixed expander for 9 months, we took from 29 to 38. So the fixed expander delivers 9 millimeters. So we've got 9 millimeters right here in the fixed expander, upper and lower. So now we've achieved 29 to 38. Then we get to the point where we've got to move on to our clear aligners and the myofunctional therapy and the Frenum revisions. But the clear aligners begin where the fixed expanders left off. So the left side of the screen is the end of the fixed expanders. And then we go through 12 months of aligners to get to 41. So 38 to 41 would be 3. So we went 29 to 38 in the fixed expanders, that's 9. Then we go 38 to 41 in the clear aligners, that's 3. We have 12 millimeters of change divided 9 to 3, fixed expander, clear aligner. So hopefully that's crystal clear now. I must have maybe not presented that as clear as I could have.
That's okay. And the follow-up question to that, is this typical for your kids that are above 12?
Typical, yeah, we do this all the way to 18. So yeah, in my world, we do that to 18. It wouldn't matter if she walked in at 17. We do exactly the same thing. Fixed expanders first, and then clear aligners second, because that the maxilla and the mandible with the proper technique, it's, again, at the beginning, we read that disclaimer. It's not meant to be medical advice, and you're not learning how to do this tonight.
Right.
You're learning that it exists. So you don't run to the office and do 12 millimeters of expansion on 18-year-old without having a technique for that. So I do teach that technique, but not tonight. So the idea is, yeah, I will use fixed expanders from 8 all the way through 18 years old in children who come in deficient, and the goal is to get them to 40. So over my 20 years, what I recognize is that healthy kids begin at 40 millimeters between 3 and 14. I don't meet healthy children under 40, and very few kids are even anywhere near 40. So we're talking these kids come between 20 and 30 is where they are, and we need to get them to 40 and above if we want to achieve, overall health. Anybody can make some front teeth straight, but that's not really what these kids need. What they need is foundational growth and development, because it's the jaws that dictate the size of the airway and the breathing. And then when you get the size of everything right, then you get the training in the musculature. That's what the myofunctional therapy is for. And Frenum releases when indicated. Now you really are delivering all of the components of collaborative care to heal a child like that. So that is a full resolution of the symptoms, which is very common in our practice. We don't really end up with children that remain unhealthy as long as we do foundation first, teeth second. And it's one of the reasons why I don't do anything that is kind of tooth only type of technique. You really need to get these kids a foundation, then the teeth second.
Great. And I think we'll end probably with Christopher because we do have more questions. But if there's that patient photo, your favorite photo, is there any difference that you can see with the patient seated upright versus reclined when taking the photo of Lauren?
Oh, the tongue.
Yeah.
In the center. Yeah, we take that upright.
Thank
So,
you.
yeah, that photograph just sitting upright. It's basically the photo is taken with the lip retractor in right after the bite. So I should show that again. It's such a nice photo. Let me bring
Sure.
that up. Okay.
Sure.
I know it's my
That's
favorite
why I
photo.
stopped you.
I know. I want to do I'm going to do a presentation where I only show this one photo and talk about it for an hour. But this is one of my favorite pictures. So you can see the lip
Right.
retractors in place. And this is the preceding photo. So when we put the lip retractor in, we have them bite down. We take this picture. Once you take this picture, and these are all sitting upright, we're just taking these pictures sitting upright. We ask the patient, open up a little bit. And usually that's where we stop. We just say, would you open a little bit? And they'll open a little bit and we just start taking pictures. So I'll take a few photos like this because the tongue will move a little. Maybe if they had to swallow a little, they might move it a little bit. But this is a nice picture because you do want to see what does the tongue look like? Can you see the lateral borders? Are they scalloped or not? And how does it compare to the size of its home? And it doesn't have a good home to live in. So obviously closing this mouth, the tongue goes back. It's an obstructive sleep apnea condition. So yeah, that's a nice photograph. Everybody should start taking that. Feel free to take multiple of this because the tongue's a moving thing. It's going to move around. It'll be here, there, and everywhere. But once you start taking those photos, you start to get a sense of, does it really match? It doesn't. It doesn't. You're going to recognize it doesn't. And then you need help because no one's going to move those teeth alone to get that tongue space back. So tooth movement alone will not improve her conditions, but foundation first, teeth second can heal that child. And that's to full healing in every category.
Wonderful.
So then,
okay.
Next case, right? You want to go?
Next case. Thank you.
Christopher. Okay, so we meet this nice young boy. Where are we? There we go. So he's 9. So we meet him at 9 years old. And again, his struggles didn't begin at 9. They were earlier, but he's really struggling and this is his look. So again, similar credentials, just a little younger. So 9 years old, shows up like this. And this little guy has, struggles in every category. So waking every night. Most parents, when you start talking and asking them appropriate questions, you are going to meet parents who will describe bad sleeping habits that are going on, meaning they're waking up at night, they're tossing, they're turning, they clench and grind their teeth, or they have night sweats, or they wet the bed, or, they are doing all kinds of things that are giving, the family lots of trouble that they're struggling with. So waking up every night is definitely one that you're here, and you're going to meet people who will tell you, we don't ever remember sleeping through the night yet. It's been an hour or 2, maybe 3. And they're up every night, waking up every night. So when a parent says they're up every night, it's not an exaggeration. They're probably living that nightmare. And then, you are in the best place to help. So enuresis is the fancy word for bedwetting, night sweats, night terrors, snoring, mouth breathing, struggling in school. And then, of course, similar credentials in that the picture you're looking at is my before picture because he's showing up to meet me for day 1. We're just getting started, but he has actually just had a year and a half of phase 1 orthodontics somewhere else. So we're going to look at, again, a very similar opportunity where we're going to see the before set of photographs. But again, it was a tooth-focused approach. So this tooth-focused approach will be the judge of where he got with that versus what we're about to do. You get to see it both ways. So here he is coming in. Now, all of these troubles, none of them began yesterday. So again, if you're doing the full history with the parents, you start talking about their child, you recognize that a lot of stuff dates back to age 3. Parents will start to talk to you between 2, 3, and 4 is when the struggles began. And all of a sudden you start to get it and put it all together, what they had when and when it started. The kids come in at 9, they're suffering for 6 years already. So we're very late meeting this child at 9. So profile photograph, he doesn't have lip seal. He looks like some of the pictures that you saw in the previous presentation that were presented as far as the mouth breathing component. This is a child who is 24/7 mouth breathing. If you can't have lip seal because this is your overjet, you could see those dry lips, you can see the mentalis, you can see everything that was pointed out. So Broom, if you're thinking about Broom, you've got all of that checklist right here in this patient as well. And sure enough, we have what we would consider underdeveloped jaws. But here's a nice picture, because this picture gives us an idea of where we're starting. And this, again, is my SEP. I just took this when we met him at 9. So when we meet him at 9 and we take this picture, this is what we're really interested in, the tube in the center. So the air's got to go in the nostril. So let's follow airflow. Air goes in the nostril. It's going to go up into the nasal cavity. Then it's going to get to the nasopharynx, then the oropharynx, then the laryngopharynx, and then it's going to open up again down here. So at the level of the neck, you can see how wide the tube is. It's kind of like a garden hose. But all the way, the rest of the way, it's really tiny, like a coffee stirring straw. So who wants to breathe through that? Now, we recognize excess overjet, the lip incompetence, the mentalis is strained, but all of this malocclusion we've got, don't forget, this is an x-ray of after a year and a half of a tooth-focused phase 1 orthodontic program somewhere else. So when he gets to us and we take that picture, we right away, we know this is part of our problem here. He can't breathe. And if he can't breathe, it's a direct relationship to where are your jaws. If you're narrow in back, it occupies, the airspace room. So smaller airway comes with underdeveloped jaws, because the airspace or airway or whatever we're going to call that, it's not a structure, it's a space. And that space is built by where are your jaws. So when your jaws are wide and forward, there's a bigger tube to breathe through, which makes for better nasal breathing in a healthy child. And this child has jaws that are narrow and back. So let's take a look and see where we are. So here we are with the anterior photograph. So we could almost see in this picture how V-shaped the arch will be when we see the whole thing. And so we have this V-shaped arch with a little bit of overjet. So we have this overjet, and the lower jaw is kind of trapped really far back here. And sure enough, we have that V shape we were talking about. So this is not a proper home for his tongue. That tongue isn't going to behave well in that space. So he's going to need all of the orofacial myofunctional therapy we're talking about. And he walks in with this because he's post phase 1 treatment somewhere else with a nice tooth focused approach. But what you recognize right away is, well, where are the primary canines? And we have 4 incisors, but we're still waiting on canine premolar. So this is a subtractive technique. So because he's 9 years old, those primary canines were taken out to alleviate the crowding of the 4 incisors. So basically, this was a subtractive technique. What happened here is 1.5 years in, braces, and he did have an upper expander, which an upper expander only is almost useless. So now you have this child who comes in wearing this lingual control arch to so-called fix the gains that were made for the last 1.5 years. But meanwhile, the gains aren't really gains because a subtractive technique was employed. His lower canines were removed to straighten the front 4 teeth. That's not additive. That's not growth and development. This is reduction. So now we've taken out 2 teeth to have these 4 align, but now we have no room for the others. So when you do talk to the parent about this pathway, we learn from the parent that this is phase 1, but phase 2 at the same office, if he goes back, is going to be 4 by extraction, because there's no room to keep them on the lower, but the upper 2 bicuspids have to come out to close the overjet. So when we take a look back, we've got this arch shape like this. We've got overjet like this. Well, the lower bicuspids won't fit, so those will have to come out. We got to lose those 2, and we need the upper 2 to come out to get the top back. But remember this picture? So who wants to retract this child now, looking at this? He can barely breathe, but now we'll take out the 4 bicuspids and retract this all back. That's not going to help him. That might make things worse. So he had a tooth-focused approach that was retractive and subtractive in nature, and he's still struggling to breathe, sleep, etc. So we're going to go the other direction. Let's get him involved with the orofacial myofunctional therapist. He had his tonsils and adenoids taken out at age 6, and it offered him about 6 months improvement, and then it went south. So he went right back to his standard, poor breathing, poor sleeping, and credentials by removing those. And we get it because you took out the contents of a very tiny tube. So if you have a coffee straw to breathe through, and you empty the contents, let's say you fill up that straw with something and then you empty it out, that doesn't make the straw bigger. It just makes it empty. So you still have a straw. Well, the problem with the adenoids and tonsils is that most of the time when you remove them, the small airway isn't sufficient for nose breathing. So the child will mouth breathe. Tonsils and adenoids removed, small airway, mouth breathing. Guess what mouth breathing does? It irritates that tissue that should be healing, and it all grows back. So he ends up having to have his adenoids taken out again because they all grow right back in. So there's a very, very low success rate for tonsil adenoidectomy to treat OSA in kids. It's 27% initially, but it drops to 9% at 36 months because the adenoids in the tonsils grow back. It was all done at Stanford University. Dr. Christian Guilleminault showed nasal breathing is really the ultimate outcome for these kids, not removal of the contents. So because his foundation is so poor, we need wider and forward. We're going right into expanders, but we'll get an upper and a lower. So upper and a lower, we'll need some brackets in here because the subtractive technique has closed off the lower space. We're going to get some brackets involved. We're going to get some springs involved. We're going to start growing everything out. So foundation first, teeth second. We are definitely going to get involved with myofunctional therapy and frenum revisions, and then we'll go to clear aligners as a second phase. So this is what it might look like when we've got the expansion done. So now we have the maxilla and the mandible totally solved. But then we'll get our brackets and wires going and put some springs because we want to slowly grow our space back. But what you recognize in the picture is there's no overjet left. So we gave him that large expansion first, then the bracket and wire to coordinate and shape an arch, the springs to kind of grow everything into the spacing we're supposed to have for the teeth. And all of a sudden you can see here, We've removed the upper expander, but now we've got the full arch development. We have the lower in place with the springs to gain back a spot for every tooth, because we do want to keep all of the teeth. It's not an extraction case, because he just needed foundation first, teeth second. Then, of course, we could look at this, and this is just 10 months later. Now, in 10 months' time, we don't have the overjet. We've got a bigger maxilla, a bigger mandible. All of the teeth have an opportunity to come in here. And now, when we take everything out of there, we need the myofunctional therapy going. We don't use retainers or anything that is fixed, because he's a 10-year-old going on 11. We need to continue to grow. So there's never anything fixed after the expanders come out, because you need that tongue and lips and cheeks and breathing to work the, the jaw growth afterwards. So now what we want to do is get involved with the myofunctional therapy, and we'll deliver what's called a guidance appliance. So there are different guidance appliances out there, but any type of guidance appliance is removable, and their focus is really on the breathing and the musculature, not the teeth. So that's exactly what we need in the interim, because we're waiting for more teeth to come in. So at this stage, it's myofunctional therapy, Frenum revisions. The adenoids had to be removed again. And then, of course, we'll use a guidance appliance for a couple hours a day plus overnight to make sure it maintains the breathing and the musculature supportive of the myofunctional therapy, so we could keep going in the right direction. So here, this is, again, just a 10-month difference. So in 10 months' time, we now have the expansion achieved and the alignment achieved and everything taken away, and we're heading in the right direction. So the jaws are kind of growing. We have just started addressing the musculature with the myofunctional therapy. And the lower jaw with the upper growth will release forward. So the overjet that disappeared, it was not by elastics. There were no elastics used. So even though he might have had like an 8 or 10 millimeter overjet, the moment the upper is developed nicely and the lower is developed nicely, it turns out transverse development with releases the mandible forward. And so Dr. McNamara did wonderful research on how you do transverse development, and it actually gives you a forward movement as well. So then we get to here, we can take this picture to show, yeah, well, we're definitely traveling forward, because while the overjet is reducing and we're heading forward, the tube is opening up. And this is only 10 months. So 10 months later, we have wider and forward. And now we've got that tube starting to open up for him, and he starts to change. So what happens in just 10 months? Well, all of a sudden, at about 8 weeks of expansion of both jaws being wider, the tongue has enough room, he can start sleeping through the night. The bedwetting stops at 8 weeks, and then the night sweats disappear, the night terrors turn into dreams. He starts to describe dreaming. So, it's amazing how a lot of kids who are having all the nightmares, when they first start to have dreams, they will tell you, I don't ever remember having dreams. I'm having dreams now. So I dream the whole night that I'm sleeping instead of have nightmares. I used to have nightmares all the time. So then silent nose breathing is what parents would report, which is very nice. And in the beginning, when he was working with the myofunctional therapist, he was struggling so much at school. As a 9-year-old, he couldn't say the alphabet without making mistakes. Part of the work at the myofunctional therapy office is to record the child speaking and eating and drinking and doing things, so they learn where are all the muscle patterns at the beginning and then working them through accordingly. Well, it turns out, given multiple attempts to just say the alphabet, he would make 2 mistakes as his best attempt and 6 at his worst, really struggling academically. Of course, if you don't breathe well, you have cognitive deficiencies. That's documented very well in the research. Children who mouth breathe alone have lower IQs than children who nose breathe at night. You don't have to have OSA to have cognitive impairment. So the research is very clear. Dr. Karen Bonnick did all this for us. Mouth breathing alone, mouth breathing, snoring, or OSA, they're all bad, but mouth breathing is enough to reduce the cognitive abilities of a child versus nose breathing. So we get through 10 months, and now he can read Harry Potter out loud, and him and his mom do that as a nighttime routine. At this point, he reads the Harry Potter books to her, and they go through the whole thing. Now we're going to get rid of our expanders, move into guides, get some myofunctional therapy going. 15 months. So we're just progressing through the case. Now we've got this wide open maxilla. The teeth are starting to shape nicely. And now in the lower, we have what would be considered mild crowding. So we have mild crowding in the lower, a tongue that has its chamber, and we haven't even gotten to the clear aligners yet. This is just fixed expanders first, some brackets and wires to regain the space that was lost by the subtraction technique. And then we're here. So now in about 15 months' time, you have a different kid on your hands. All of a sudden, this child is nose breathing, sleeping through the night. And now you've got your permanent teeth coming in. And of course, we're going to get to clear aligners. So you could recognize a couple of attachments, but we'll use clear aligners because he has a class 1 mild crowded, slight issue with the teeth. We'll just do tooth coordination now. So foundation first, teeth second, delivers beautiful alignment. Class 1 connected. If you have to see canine to molar class 1, it's right here for you to see, but it's not really about where the teeth are. It's about where the foundation is. That's the priority. Then you get your teeth second. That's how you heal a child. So the child goes through, I think it was about 8 months of clear aligners. So 8 months of clear aligners. You get a school picture during the aligner. So all of a sudden we've got the broad smile. He's got a hairstyle going, the kid's waking up. So he becomes the equivalent of an A student, no more struggles. He rejoins a basketball team that he couldn't participate on very well because of his behavior. He becomes a drummer in the school band. He does switch over to soccer. He begins playing soccer, goes all the way through varsity soccer. And now we get to, maybe we might be here, finishing up our clear aligners. And as he's finishing his clear aligners, all of a sudden you've got the hairstyle and, wow, you're looking good. But we knew you were here because the Axe cologne came in the office about 20 feet before you did. So we had to make advice about maybe don't use the entire bottle of the Axe cologne. You can use a little less than that and still be okay. Here he is in 2021. This is just last year because he's fully grown. He has his wisdom teeth in place. So here he is in 2021. We're just checking him. He's probably about 18 years old here. And at 18 years old, he has, you can see in the back there, I know my top mirror wasn't as clear as it should be, but here come 4 wisdom teeth erupting with comfort, and they will erupt right into function. So his wisdom teeth erupt with total comfort and into function. And now he has 32 teeth as a full complement, but meanwhile, he has absolutely no symptoms. He's a class 1 bite everywhere, which is beautiful. So here he is, of course, at age 18, you're too cool for school. And of course, you got a hairstyle going and you're the varsity soccer, player, and you're, doing wonderful things in school with your grades and your sports, and you're going to get into a great college and have a wonderful future, all because you had growth and development first. The foundation first, the teeth second, delivers a healthy child. So he has absolutely no symptoms in any direction whatsoever. He closes his mouth when he goes to sleep and he breathes through his nose. And I think that might be the time limit on us there, Lauren, right?
Yeah.
Yep. Yeah, we had
Yeah,
more.
let me just get my video. Yep, we have lots of questions, and we want to get through some information too on our upcoming courses because there's a lot of questions about that.
Sure.
But, I'm going to start with the questions in the chat here. And one actually that we're going to refer to is just a pretty hot topic. Joan McCoy asked, I learned in the news recently that some expanders were actually causing teeth to move through the buccal plate of the maxilla and leading to severe bone loss. Is that a particular appliance versus what you use?
So yeah, it's not a specific question. So it's probably referring to the news about the AGA appliance, the AGGA is my guess. So I will answer with some assumptions that the recent case that was brought into the public was the AGA, the AGGA. That's an anterior growth guidance appliance. So I guess the important part would be to preface this with, well, I don't know a single detail about that case. I don't know the treatment. I don't know the styles. I don't know the designs, but I do know what AGA means. AGA means anterior growth guidance appliance. So I don't use anterior growth guidance appliances because my diagnosis is in the width. The children are narrow, so they need transverse development. So we only use what we call expanders that are developing transverse, and transverse gives you forward. I never go for just forward, and AGA appliances come fixed or removable. So to be honest, I don't know if that patient had a fixed AGA or a removable AGA, but all I know is AGGA stands for anterior growth guidance appliance. I do not use those. I do not teach those. I do not develop length, because when you turn into what is a diagnosis, I don't diagnose that the patient needs length. We diagnose that they're narrow. And when you're narrow and you develop the transverse development, it turns out you get forward growth by that. And that's all nice research with Dr. McNamara. So transverse, width, and narrow, when we think about narrow, not only is that the diagnostics that you're looking for because the kids come in narrow, but narrow is all over the research in the sleeping and breathing. It turns out your phenotype or look of your sleep disorder breathing, snoring, mouth breathing, OSA patients, the phenotype is narrow and vaulted, narrow and vaulted. So narrow and vaulted doesn't need to be longer. Longer doesn't solve that because now you're not treating really in the cause category. Longer can mean teeth can fit. You can make teeth fit. So for me, the AGA wasn't really a choice to treat with. So I've never in 20 years used an AGA, and I don't really know enough about it to comment about that case, but the bare minimum would be I teach and I do transverse development because all of the research and all of the diagnostics point towards the kids are narrow and underdeveloped. And in my world, I'm looking for width. And when you deliver width, you do solve the phenotype of OSA and sleep disorder breathing. So now you get your breathing improvements too. So for me, the AGA isn't a pathway. So yeah, moving teeth through the bone is totally possible. That comes from poor technique. So you would combine, what were you trying to achieve? What was your diagnosis? What was your technique? Because while we treat a lot of adults, we do it differently. And a lot of it has to do with technique. Anybody can have a poor technique and force a tooth through the bone. And so nobody's looking to do that. So now you need to have a proper technique depending upon the age. So appliance selection, technique all go into developing the foundation and then coordinating the teeth second. And we just don't do anything that involves length forward. We do width.
Do you often place lingual bars or just retention appliances after clear aligner treatment?
So after clear aligners, I almost never put a lingual bar in. And so after clear aligners, you get a clear retainer and you wear a clear retainer to bed every night. For the children that we treat early with the growth and development and then the myofunctional therapy, and then if we use clear aligners or braces for tooth alignment, because any child that you treat, when they get to 12 or 13, and we're thinking about the final phase is tooth coordination, at 12 or 13, it's okay to have braces provided you did the full foundational development. So the kids who get braces in our hands are basically kids who've had the full foundation developed first. So after foundational development, it could be braces to align the teeth or clear aligners to align the teeth. Either way, we talk to the parents about their options. You're going to get a clear aligner retainer because you're looking to maximize tongue space, and clear aligners as a retainer will maximize tongue space for better breathing. But then, of course, in children who are 13, 14, 15, are they going to go all the way through high school and wear their retainers well, their clear retainers? So it's not a bad idea to put the fixed lingual bar maybe around age 15 or 16. So we delay that until about 15 or 16, add it, because now we know high school, college, if they get sloppy wearing their retainers, nothing will really shift or relapse. The one item we have in our favor is that because we give the foundation back, then address the myofunctional therapy, technically you don't need retainers at all. So if you have the breathing and the musculature right, that's your retainer. Your tongue is the scaffold that keeps the arch nicely put in place. So the kids who receive foundational growth and development first, followed by myofunctional therapy, and then alignment of the teeth last, that technique doesn't really require retention. And because we're doing this for 20 years, I have an abundance of college kids who come back for their cleanings, summer and winter, right? The college kids that we treated come back and we ask, hey, how are you doing with those clear retainers? And they stop wearing them. So most of those kids stop wearing their retainers, yet they have no relapse. So relapse after doing a tooth-focused approach without attending to the muscles is very high. So braces alone from 12 to 14 really proves out to be a situation where you are going to have relapse at a very high rate. In fact, the ortho research states that completion of orthodontic treatment does not guarantee stability. Retention is for life, because the overwhelming majority of people are going to collapse. And that's because the tongue isn't right. And if the tongue is weak and the outside is strong, of course, that drives the teeth in. So relapse is very common unless you address this way, meaning foundation first, breathing and musculature, then teeth last. All of a sudden you have everything built into retaining it without retention.
Okay, great. For adults with maxillary expansion, patients who are concerned with or do not want a diastema between 8 and 9, are there different techniques for expansion, or is it more case by case where the spaces present?
Yeah, so the space between 8 and 9 is either non-existent or very slight in an adult because it's the pace at which you're growing the maxilla. So when we treat adults with foundation first technique, we're using removable expanders. So a removable expander is meant to be worn in a cycle of pressure and tension. It's in, it's out, it's in, it's out. But the rate of its growth is really slow. So because it's growing really slow, 8 and 9 really don't separate that much. You might get a hairline, you might get a millimeter, but you're not going to separate it like a child getting rapid maxillary expansion, which I don't do anyway. We'd rather have slow expansion as kind of natural or kinder. So for an adult, there's less of a concern about the spacing between 8 and 9. More adults have crowding. So if you have crowding, there's really no concern because the teeth will start to unravel. And having a small space between 8 and 9 is a good sign because it does mean your maxillary suture is starting to separate. So when 8 and 9 do separate just a little bit, that's a really good sign that your removable expansion technique is growing the bone and not moving your back teeth out, because your expander on top has nothing to do with teeth 8 and 9. And yet when 8 and 9 separate a little bit, we're looking for that. So that's a really good sign that you're heading in the right direction. So we're not opposed to seeing a hairline to a millimeter, but it never really gets more than a millimeter because the rate you're growing the foundation is the rate at which 8 and 9 can relapse back together. And 8 and 9 want to stay together, so they keep coming back together. So it's kind of a back and forth all the way through. In the end, you're getting clear aligners anyway, because foundation first, teeth second means clear aligners are second. And with the clear aligners coming, you can close any little space you got between 8 and 9 later.
What age do you think it's best for those children who have narrow arches to start with expanders, or what may you use for early intervention?
So different techniques are available. So in my world, I start at 3, but we have on our call was Dr. Kevin Boyd, pediatric dentist from Chicago, a mentor of mine, and I know he begins even younger. So basically the time to start is when you meet the child and have diagnosed an underdeveloped jaw, because underdeveloped jaws come with sleeping and breathing issues, and those can impact a child's development. And all of the formative years are really 0 to 6. So starting at 7, we're late, because from 0 to 6 is where you have all of the cognitive and everything happening earlier. The behavioral, the social, the cognitive, all of the formative years are 0 to 6 years old. You don't need a child who's 2 or 3 with underdeveloped jaws and no space in the primary teeth breathing that badly and sleeping that badly, because now you'll have a child who is unhealthy later on. So Dr. Boyd teaches even younger, age 2, like he can get involved with 2 and 3-year-olds. And I've never been good at handling that age group. So 3, I begin at 3. So between 3 and 4, we get started. Dr. Boyd has incredible removable expander techniques at that age. I jump in a little later with fixed expanders, usually 7 or 8 years old. He also has wonderful techniques for, basically management, because in those ages, you got to really handle those children wonderful. So he's terrific at that. So I'm not the best at doing the younger age groups, but I do know the rule. When you meet the child and diagnose the underdeveloped jaws is when you begin treatment, because waiting doesn't help any child. So don't wait.
Right. And a lot of the questions that we received either via email or in the chat are related to technique and how do we do all of this. So I just want to take some time and invite Brittany and Carice to talk about our TeamMYO courses. And then at the end of this section, we're actually going to do a raffle. We're going to do a live raffle. I'm so excited what technology can do. So it's random, and we'll all see together who wins a tuition, which is almost $3,000 price point to join us for our 8-week or 6-week course, depending on your status as an OMT. So that's going to be exciting. So stay with us to the very end to see who wins that prize, and also to get more CE information. But Brittany and Carice, let's talk about your courses. I'm so thrilled with the work you've done, and I just want to give you a shout out, because I don't think people quite understand how we judge our courses. We actually have an NPS score, which is a net promoter score. And it goes from negative 100 to positive 100. So 0 is actually average, okay? So we strive to have an NPS score of 50 or better. That's actually exceptional. I think Apple has like an NPS score of the high 60s or low 70s, but it's an actual measurement. And Brittany and Carice, they got 100 NPS score from their survey. So, I mean, that is really outrageous. And actually, so did Dr. Moralia. So I'm just saying kudos to everybody, because we really try to have some tangible evidence of how we're doing and how we can improve. So I just wanted to start that baseline, because not a lot of people know that. And we've had wonderful testimonials. And it's because of your caring ways, your passionate ways, and how you really want your attendee to flourish and really help people and establish that confidence and competence to become a myofunctional therapist. So thank you guys. You're a great addition to Airway Health Solutions. So let's talk about some of the options and what courses may be best for what type of practitioner.
Thank you, Lauren.
You're welcome.
Now we have to follow Dr. Ben. I mean,
Tough act to follow.
Okay, so the 8-week myofunctional therapy course is an introductory course that is great for anybody who is new to myofunctional therapy. You're going to get 5 hours of pre-learns. You're going to get a foundational level approach to myofunctional therapy. And my favorite part about the course overall is really that we get to, at the very end, test all of the competency and the knowledge. So what we're really going to do is have case studies where you as a student are confident enough that you can present your own beginning of a case. And so I really love that course. In 8 weeks, we really do traverse a lot of great topics, and it is a phenomenal course for anyone who's brand new or anybody who's looking to review foundational information as well.
Our 6-week MYO course, similar, but you're coming on at that 3rd week, which is going to start with our exercises. So this is for the existing OMT. So you might have taken another introductory course, still feel not very confident, not ready to really move on, wanting to learn a little bit more. One of the things that I love about working with Carice is we have a lot of the same values when it comes to myofunctional therapy, but we also practice different ways. So it's really cool because you're getting each of our views on all of the subjects. And, you know, our end goal with our patients is the same, but the way we kind of tackle it can be different. So I think that that's really cool about our course. So that 6-week course, you're going to hop in on that 3rd week.
And then the mini MYO course is going to be live again. So we sold out the first time. It's available on demand. If you are a self-study, self-paced learner, you can get it on demand, available now. But if you would like to join us for the live run of it, it is 5 hours live on October 6th. We'd love to have you. It's a wonderful course where we show 2 evaluations, I'm sure, in a couple of different cases. You get to see exercises and really learn how to work with the age population under 6, because, you know, we want to fix before 6. So if you get them a little bit before then you're able to really intervene on a lot of those early oral habits and detrimental compensatory patterns that develop.
Then we have our MYO Merge course, which is now available on demand. This is for practices that are struggling, really being able to integrate that myofunctional therapy component into your practice. So we really help to give you the skills and the knowledge to feel confident about integrating that. So again, you can be offering that myofunctional therapy, that expansion service, all in the same office.
And if you're looking to do MYO independently and you really want to up-level your business skills, we have AHS MYO Solo Success. So with Solo Success, wow, that was a lot of S's. With Solo Success, you're really going to dive deep into how you can build your brand, how you can scale your practice. If you're already existing and you're really reaching a plateau, you're not sure how you can connect and really collaborate and cultivate your team and your network. It's a phenomenal, another 5-hour course that is going to be on demand, and that will be coming soon. So please stay tuned for that.
We're very excited for that course. That's our new little baby that Carice and I have been working really hard on. It's super exciting. And then we have our Intro to MYO course that's also on demand. That's going to be coming soon on our platform, and that is going to be self-paced. And then no matter what course you take with us, you do get to be in our TeamMYO alumni group on Facebook, where we hold quarterly Q&As. We're there for any questions. It's a great community, open community, accepting community. You can put case studies on there and ask any kind of questions, and we'd be happy to help you answer.
Wonderful. And we're so excited. So these new courses, the Intro to MYO course will be available August 1st, and we're pushing for August 1st for the Solo Success, if I can say it. That's great. That's a tongue twister right there. And we're also offering some coupons. So this will be in your follow-up email, but we love to get, especially for our first time courses, and we're just doing a summer celebration. So we want to extend this to you with these coupon codes. You can see them here. I don't need to read them, but they will be in the follow-up email as well. So you can take advantage of these price points. All right, Dr. Ben, let's talk about our mini residency. This is like our baby, right? We're going to be 5 years old coming up. We're going to have no celebration, but wow, we've had 5 years of our pediatric and adult mini residency, and we've trained over 400 doctors, and in turn, they have treated thousands and thousands of children all over the globe. So let's just talk a little bit more from from your heart and soul about these courses and what our attendees can learn.
Yeah, so these are the technique courses. So, we talk about our pediatric mini residency course as being full technique. So what you learn in that course is the pathway, which is going to be, you're going to collect records first. So you need diagnostic records. You're going to need to have a consultation with the parent. You're going to have a beautiful consultation result in how soon do we start? And then you got to learn how to treat that child. So basically in the pediatric mini residency, it's everything from the starting point of collecting records to then treating a child between the ages of 3 and 12. So it's everything at your disposal to treat between 3 and 12. And that would include guidance appliances. That would include Frenum assessments, and then myofunctional therapy guidance. It would include fixed expanders. And then, of course, with all of that, by the end of that pediatric mini residency, you would learn how to handle a child between 3 and 12, regardless of their condition. It doesn't matter how they come in. They basically come in underdeveloped, crowded, narrow, whatever it might be. But you're going to learn everything from how you got there to how you intervene and how you get that child to be 12 years old and have a mild class 1 that has no symptoms. So we're looking at, generally the technique is foundational development first, followed by tooth coordination second, and it does include the breathing, the musculature, and all of that is related, of course, so it's all inclusive of the collaborative care effort.
Great. And then the adult mini residency, there was a question here is, do you offer a course that focuses on adult airway disorder?
We do. So we focus on adults too, because adults come in with crowded teeth and bad bites. And if you've got crowded teeth and bad bites, it means your foundation is underdeveloped. And if your foundation is underdeveloped, chances are you're not the best breather or sleeper that you could be. So we talk about, again, our expansive techniques for adults. So the adult course focuses on our 2 best opportunities for foundation and teeth, which would be removable expansion appliances. So we learn what styles and designs of removable expanders can be used in adults, and then a proper technique to do it that generates growth and not just forcing teeth through the bone. Then, of course, we learn about clear aligners, because clear aligners are an amazing technique for really any teen to adult to have. And clear aligners are generally expansive, but you need to have an expansive technique taught so that you would then use it appropriately. So we do teach an expansive clear aligner technique. So adults, again, it's about diagnostics. How are we diagnosing them? And then getting them involved with expansion. And that could be clear aligners alone or removable expanders with clear aligners. And of course, in the adults, we do talk about the Frenum assessments, releases with myofunctional therapy, because myofunctional therapy, as we learned a little bit ago, it benefits at any age. And there is research to show with myofunctional therapy, you can improve or reduce an AHI or OSA diagnosis because you're retraining all that musculature to behave itself properly so you can breathe better. So all of that included in that. Again, technique related to foundation first, tooth second, all of it expansive, teeth wider and forward.
Wonderful. And now Dr. Boyd was with us earlier, but I would invite him to tell us about his course. But Dr. Moralia, you were there for Dr. Boyd's course twice now. Tell us a little bit about your experience of now seeing your mentor, of co-teaching with him and co-presenting, and what our attendees can expect.
Oh, yeah. So it's an absolute honor to stand anywhere next to Dr. Boyd. And so, yeah, he gets involved so much earlier than I do. And then to get involved so much earlier and make a bigger difference sooner is impressive. And as his background is in pediatric dentistry, so he knows the entire management component, which, you know, I don't have that down. I know how to play with a 3-year-old, but to treat 2 to 3. So my problem is trying to get them to do what I'd like them to do. But he's got that covered too. So yeah, to learn from Dr. Boyd is pretty special. He is obviously heavy technique, but also heavy research. So he has the most phenomenal research as part of his presentation. And so I touch on research. I have my components of research, but his is totally technique and research based. And it is absolutely phenomenal. And he's one of the best advocates for early growth and development techniques for children so that they could sleep and breathe better. And he refers to it as the craniofacial respiratory complex, because he knows it is really about the breathing, sleeping, and overall human being, not just the teeth. So what an opportunity to learn from him. I will be there at that one too.
Yeah, and MYO was actually the product of Dr. Kevin Boyd. He really insisted on having that course because he needed that follow-up after his course for that resource. So thank you guys for helping Dr. Boyd there with his dream come true. And also, I just want to kind of go back to the course October 6th will be also live in Florida. So you'll be there October 6th, 7th, and 8th. And Dr. Boyd also recommended that we have Dr. Moralia's pediatric mini residency as the prerequisite for his course. So this way it's not too much information at one time. So ideally, if you're into pediatric growth and development of the respiratory complex, you'll be with us in Florida, October 6th, 7th, and 8th, or you can attend virtually. So we're really excited to have these live learns back. Then we have our advanced mini residency. A lot of people asked in the comments, well, what do you do with older teens? And what about braces? Are they bad? Can you explain a little bit about this other baby of yours that you love now?
Yes, of course. So the advanced mini residency picks up at 12 and takes us 12 to 19. So basically 12 to 19 is that world of those teenagers that come in, because we do meet kids at 14 and 15 and 17. And so sure enough, they've either had no treatment or they might have had a different opportunity that was tooth focused or retractive or extractive, and we have to help them out, of course. So from 12 to 19, this course is built to learn about fixed expander techniques that are available from 12 to 19. And of course, again, it is the same philosophy of foundation first, teeth second. So I don't meet teenagers or 12 to 19. I don't meet children in that age that get braces only. So in my world, I do not use braces only because that is a tooth-focused approach. Braces will line up the teeth, but we really need the foundation first. So braces are not bad, provided you have two things accomplished. Number one is you've grown the foundation. So foundation first, wonderful. That's the technique. We grow the foundation first. Then you can use braces. But the second thing is, what braces are you using? And it turns out there is an expansive bracket and wire opportunity, and we teach it. So it's not the traditional kind of twin bracket you might recognize from the ortho specialty where they have a little, that safety tie ring, colored ring on the, it's a self-ligating bracket system, because passive self-ligation, it's part of an expansive technique. After you've developed the foundation, you can maintain or increase your width, not decrease or keep it narrow. So we don't want to get involved with brackets and wires that are retractive in nature. We want to grow the foundation first and then use an expansive bracket and wire product and technique. And we teach that all in this class. It's a wonderful program. I'm very proud of it.
And that will be held virtually as well. And it's a nice intimate group. We hold Zoom meetings. It's not a webinar, so it's very interactive. We have Dr. Brett Christensen joining us with an airway orthodontics pediatric mini residency. It's an orthodontist teaching orthodontist, and the general dentist is also invited. So you'll have so much to learn from Dr. Christensen. He's been doing this for 30 years. Dr. Morelli, you want to comment a little bit about Dr. Christensen's philosophy and just how it just jives with you and Dr. Boyd? It was kind of uncanny, right?
Yeah, it's wild that he's been doing this for 30 years. And so I believe in Idaho, where he is practicing. So 30 years of doing growth and development, early intervention. And his main part of his diagnostics is the nasal airflow resistance and measuring, nasal airflow. So he uses a lot of rhinometry. So he has the machines and he does the rhinometry, so he can kind of test and prove, hey, I've made the right adjustments to the child so that now the air is flowing better. So when you want to learn about, research and kind of proving and numbers and statistics and learning that, hey, did I go enough to make the difference for the child? In his world, it's all about rhinometry, pharyngometry, and he has the machine and then obviously the technique to show you so that you could learn how to do that too. And so we've been doing that now, of course. So, he's obviously a mentor of mine in that department, because I was so late to that game in actually using a rhinometer or a pharyngometer to be measuring airflow. So I'm very late to that, but happy to get there, better late than never. So I have Dr. Brett Christensen to rely on to teach me my next phase of growth, development, and proving it, which is nice. So a wonderful opportunity. And then even better for us is that he's an orthodontist, which is wonderful because it's very nice to have colleagues across dentistry and all the specialties. And as an orthodontist who does non-extraction, growth and development, airway related type of treatment on kids as young as 3, it's wonderful to have a colleague in that space to not only talk to, but then to share ideas and have collaboration. So much better than arguing.
And speaking of, well, before I get past this, and speaking of collaboration, you've been working with Dr. Gelb. We just did a great study club in New York City last night, and you presented a lot of the cases that you worked collaboratively on. Dr. Gelb has a one-day mini residency where he teaches you, it's like the prequel to ortho, if you would. So for our acute TMD patients, he teaches you how to get that out of pain and then ready for orthodontics. You want to comment on this great relationship and course that people can benefit from?
Absolutely. In our adult mini residency, we do start to introduce treating our TMD patients with growth and development type of orthopedics and orthodontics, but it doesn't come without pre-treatment with Dr. Gelb. So as a TMD expert, what he does is he gets that patient reduced to a comfort level that they can go through. So someone's got to get the disc recaptured. Someone's got to get the inflammation down. Someone's got to get the pain and the symptoms reduced so that patient can actually go through orthopedic and orthodontic. We can't take those severe TMD patients into treatment without sometimes aggravating stuff. So his pathway is he receives that patient first and gets them stabilized. And it could be a manner of a bunch of different, again, collaborative care techniques, but totally focused on airway, sleeping, breathing, growth and development, jaws, muscle, condyle, disc, TMD, everything is in one package. Once he stabilizes a patient, and it could take a few weeks, even a few months, When that patient is stabilized, he knows the next step is really to get the growth and development done, meaning grow the jaws, align the teeth, better bite, better musculature, better condyle, better disc, and then we can heal those patients. So we have that pathway of TMD to ortho, and he presents the kind of first phase for the patients in the moderate to severe TMD category.
Great. And we've been really busy, Ben. We have another new course coming on, a virtual Clear Aligner University. And this is so near and dear to my heart because this is kind of like our roots. This is where it all began, where I met you back in the day when we worked together in marketing and education. But what we're excited about this course, it's kind of coming back to basics. It's really about what clear aligners can do for everyday dentistry, for daily dentistry. And you'll see 90% of your patients will benefit from clear aligner therapy on some level, and you'll learn why. So he teaches the why, and then Dr. Morelli will also go in and teach the how. You want to just touch upon this new course that we're offering August 11th?
Yeah, definitely. So most adults walk in our practice and they have some kind of malocclusion. A crowded deep bite is the most common, but very rare for an adult to walk in and their teeth are perfect and they don't need anything. So we talk about using clear aligners, not for really the aesthetic realignment and a beautiful smile, which is incidental. You get that anyway. We talk about it as a healthy choice to deliver a beautiful occlusion, which can improve tongue space, etc. So we basically have the foundation, again, is the same, where we're trying to develop a beautiful arch form, arch width, and inclination to have incredible occlusion, as well as proper tongue space, as well as an aesthetically appealing smile. But we're looking for healthy first, good looking second. And turns out clear aligners are so capable of doing beautiful expansion and uprighting and aligning of teeth that you can do a lot of things. I think most people underestimate how powerful clear aligners can be. You just need a good technique. And so our course is geared towards using little to no IPR. And so we use little to no IPR and really little to no attachments too, because the aligners are very capable and you just need to have a good expansive technique. So that's what it all is, expansion.
And then we're offering $200 off on our introductory course. So hopefully you'll take advantage of that. That's until July 31st. And I am so super excited about this event. I mean, look at this lineup, all these dots. It just lights up my whole face right now. We actually have just secured all of our speakers, so we're really excited. You can see all the names. I'm not going to read them because we don't have time, but it's a really diverse group, and everyone offers such a key piece to the puzzle of airway health and myofunctional therapy. All healthcare providers are invited, and we do try to make it easier for you. So we are going to have coupon codes and payment plans available, so you can join us for the Airway Palooza at either a monthly rate or take advantage of our upfront discount. So that'll be all in the follow-up email. But we do have another free event. So I know tonight we had a great turnout, and we're hoping to get even more for our August 9th. We're having a free masterclass. It'll be 3 CEUs. And we do have these giants in airway presenting. And we're basically going to have the topic of pediatric orthodontics and airway health. And we're going to be breaking barriers and busting myths. And it's all from their unique perspectives of a combined, I would hate to say, but over 100 years of experience together. So not to make anyone feel old, but this is really a treat with all the superstars in airway. So please register for that. We actually may fill up for that because we only have, I think we have 1,000 webinar, and with the 400 we received for this, I wouldn't doubt it if we do sell out on this. So register today. It is a free event, and we're happy to provide that for you. We do have, hopefully everyone's coming to Collaboration Cures because this is an upcoming event. Dr. Morelli and Dr. Boyd are both speaking. Dr. Morelli does have a code that you can use for a $200 discount. I hope you take advantage of that. That's September 7th to 9th at Collaboration Cures. So hopefully we'll see you there at that time. And I also want to bring to attention the CAF Foundation. A lot of people aren't familiar with this. And if you go to their website, you will see a tremendous amount of resources for patient and parent information. Okay, so we give a lot of professional resources at Airway Health Solutions, but this is really a great resource for you to get free information. So we ask you to perhaps consider a donation so they can continue the wonderful work that they do, and go there and learn more about their story, because it's really heartwarming and touching, and you will definitely benefit from those, from all their research and their materials. So you'll get free dental CUs. You don't need to do anything if you're with us for this duration of the program. We have it recorded through the software. We will email you your CE certificate. It is dental CE. That's what we're qualified for. So if you're an SLP, you can try to push it through your accreditation. I don't know if they will accept it, but we're happy to provide you with the 2 free dental CEUs. And now I hope this works, because this is like so exciting for me, except it'll be such a letdown if it doesn't, but technology. So I don't know, I've never done this before, so we should have like a drum roll or so, but one lucky person will be the winner of tuition-free enrollment for any of the remaining 8-week or 6-week comprehensive MYO courses in 2023. You need to be in attendance during the draw to win this raffle, and the prize is non-transferable. So you guys ready?
Yes.
Okay, here we go. Goodness.
Is it not
Let's see.
working?
Wait, it has to work somewhere on this wheel. Somewhere. I know, it's probably like the little sling. Wait, let me try to right click it. Wait, hold on. I will make this happen. Maybe put it in the chat link, Gerald, if you could put the link in. Oh wait, Wheel of Nature. Hold on, I'm not doing this until we get this done. Everyone has to stay tuned. Gerald, can you put the link in the chat and I'll click on it there? Just. Okay, I'm doing it this way, old fashioned.
I know it's going to work. It'll be successful, but I got to say good night to everybody. I have to run to another meeting. It was a pleasure.
Yeah, okay.
Thank you all for your time and
Thank you so
attention.
much, Dr. Moralia.
I'll see you at the next one.
We
Bye.
appreciate you so much. Thank you. And why isn't it letting me? Oh my goodness, I'm so sorry. But this is the first time, and I couldn't do it until it was legit. Hold on. Does someone, Gerald, you want to do it for me? Because for some reason it's not letting me click on the link.
Sure.
Thanks. We're gonna get a winner. I'm not leaving. I'm holding everyone hostage here.
We're building anticipation.
I know, I can't stand it. Just don't make me sing. Okay, here we go.
Do you see it?
Oh,
Yes.
yeah, I can see it. Okay, here we go.
Okay.
Thank you. Woo, so exciting.
How exciting.
Okay, now can we? Okay, Crystal Jean DeRue. We have a winner. Is she on? She has to be on. Wait, hold on. We have to check. Because if not, we'll spin it again. Hold on.
Dr. Crystal's here.
Yay! Congratulations, Dr. Crystal. So exciting. So we really appreciate you all. And thank you so much for your patience in that. But at least we got a winner. And we are so happy that you're all with us tonight. I hope you learned a lot. I hope you get motivated if you're a hygienist of the potential you can have of being an oral facial myofunctional therapist. And whatever you're doing in dentistry, include oral facial myofunctional therapy. Get involved with the myofunctional therapist. Sponsor your hygienist to become a myofunctional therapist in your office. You won't be sorry. It's a win-win for everybody, the patient, the practice, the hygienist, everybody. So any questions, we're always accessible. Reach out. And again, we really appreciate all of you for your commitment. Thank you, Brittany and Carice, for a wonderful presentation. You really simplified it. And thank you, Dr. Moralia. I didn't get a chance to properly thank you for all you do really to raise awareness and the thousands of children and adults that you've helped around the world from your teachings. So thanks, everyone. It was wonderful being with you. We'll see you August 9th for our master class. Again, it's free. Spread the word, share the registration, and let's do this, everyone. Have a great night.